Hey, before we start the video, if you like this sort of content and you want more, come check out Med School Bootcamp. We have content for Step 1, Step 2, Anatomy, and OMM. Right now, we're about to watch the Biochemistry section. And if you're looking for downloadable PDFs, along with shorter videos and quizzes after each video to help you reinforce the information, then you can find it all on Med School Bootcamp. We also have a Step 1 question bank with some of the most representative questions to help you prepare for Step 1. You can also create a custom Step 1 study schedule when it's time for dedicated. So if you're looking to crush it in med school this year and pass Step 1, come check out Med School Bootcamp. It's going to be your first link down in the description. Now on to the video.
Hi everyone, my name is Paige and thank you so much for joining me for our chapter on protein metabolism. Another big chapter coming at you. We're going to start off with our introduction to proteins in this video. Then we'll move on to protein digestion and absorption. And then we're going to move on through a series of amino acids and their corresponding clinical implications, so the disorders that involve all of these different amino acids. That discussion will be broken up over several videos, and then we'll finish off with a summary of those disorders. Then we'll switch gears and we'll start talking about ammonia and the implications of protein breakdown. We'll talk about ammonia transport, the urea cycle, and then disorders of the urea cycle. So stay tuned. Let's get into it with our introduction to proteins. So the building blocks of proteins are called amino acids. And down here we have the structure of a typical amino acid. So the center of an amino acid is this carbon here, which we call the alpha carbon. You can see it labeled. We have a bunch of different groups that come off of that center alpha carbon. The first one is a carboxyl group. So it's connected to a C double bond O and then an OH. So all of that is one side group off of the center carbon. Another side group off of that alpha carbon is this amino group here, which is an NH2. Then also off that alpha carbon, we have a hydrogen. And then our fourth group is what we call the R group, which is a variable side chain group. And so while all of the rest of this structure of amino acids is constant between the different amino acids, it's this variable side chain group, this R group, that makes each amino acid unique. And I'll show you guys all those different examples of R groups in a minute. So back to the outline here, remember our structure was that center alpha carbon plus a carboxyl group, that C double bond OOH, that amino group, which was the NH2, that lone hydrogen, and then that variable side chain, or our R group. So that's the structure of our amino acid building block. And then we can put those building blocks together into chains. A chain of less than 50 amino acids is called a peptide. And the bonds that link together those amino acids are called peptide bonds. So a peptide bond is what happens when a carboxyl group and an amino group come together in a dehydration reaction. Dehydration is removing H2O. So if we have two amino acids next to each other and we line up the carboxyl group from one of them and the amino group from the other one, and then we dehydrate it, so we pull out that OH group and then another hydrogen, we'll be left with that peptide bond between the carboxyl group of one and the amino group of the other. So that's how you get a peptide, which is a shorter chain of less than 50 amino acids. Multiple peptides together form a polypeptide chain, and that is what is known as a protein. So there are hundreds of different types of amino acids, but there are 21 proteinogenic amino acids in the human body. From undergrad, you may only remember 20 of these encoded via normal DNA translation. However, there is a 21st proteinogenic amino acid. It is called selenocysteine, and it's encoded by something called alternate translational recoding. In reality, while selenocysteine is important, there's a reason it's called the 21st and sort of the odd one out. While it is involved in a lot of enzymes like glutathione peroxidases, we're not really going to talk about it again for the rest of this chapter. It is not high yield for your STEP exam. So here are our 21 proteinogenic amino acids in the human body. And if we just pick one as an example, let's pick alanine down here. You can see here's our center carbon, here's our carboxyl group, here's our amino group. The H group they're not going to show, it's just a hydrogen that's attached to that alpha carbon. And then this here is the variable R group. And you can identify the alpha carbon in each one of these amino acids, and you can see the variation in all of these R groups. So there are lots of ways to categorize these amino acids, and there are a couple of different categorization techniques I like to use to keep them straight in my mind. The first one is hydrophobic versus hydrophilic. So all your hydrophobic amino acids are down here, and all your hydrophilic amino acids are up here. And again, ignore selenocysteine. We're never going to talk about it again. And so within your hydrophobic amino acids, you've got a couple of categories. You've got aliphatic, aromatic, and branched chain. An aliphatic amino acid just has an open carbon chain as its R group. An aromatic amino acid has a closed 6-carbon ring as its R group. And a branched chain amino acid is exactly what the name sounds like, where the chain coming off of the alpha group is a branching carbon chain. So those are just categorizations you might hear. And then within the hydrophilic amino acids, you're going to have your polar uncharged, your positively charged, and your negatively charged, also known as your basic and your acidic amino acids. You do not have to be able to draw any of these for the exam. Just understand the different categories that these are going to fall into. So that was one categorization technique, hydrophobic versus hydrophilic. The next categorization technique we can use is non-essential versus essential. So an essential amino acid is one that is essential to take in through your diet because you can't make it within your body. Compare that to a non-essential amino acid, which can be synthesized from other materials within your body. And the mnemonic I like to use for the essential amino acids is Private Tim Hall, spelled out like that, PVT Tim Hall. And that stands for phenylalanine, valine, threonine, tryptophan, isoleucine, methionine, histidine, arginine, leucine, and lysine. Importantly, histidine and arginine are conditionally essential, meaning in times of increased stress or pregnancy or burns or trauma or anything, they become essential, but those are them. And then the rest are non-essential. And then the final category is glucogenic or ketogenic or mixed. So we've got our diagram here and it's color-coded to show you which are glucogenic, which are ketogenic, and then which are both. So a glucogenic amino acid is going to participate in the carbohydrate pathways, right? Things like gluconeogenesis, the TCA cycle, pathways that we talked about when we talked about carbs. Ketogenic amino acids are going to participate in pathways that we talked about when we talked about fats. Things like ketogenesis, fatty acid synthesis, and then they can also enter and participate in the TCA cycle. And then some amino acids can participate in both pathways. So here you can see acetyl-CoA going into the TCA cycle. And, there's going to be diminishing returns on what you memorize from this diagram. Basically, just understand that there are 7 amino acids that enter the TCA cycle at the step of acetyl-CoA through one intermediate or another. And 2 of those, which are ones that you are really going to want to know, are lysine and leucine. And lysine and leucine are the 2 ketogenic amino acids, purely ketogenic. That fact occasionally comes up in higher order questions about diet supplementation and people with different biochemical pathway disorders. If you know those 2, you can generally figure out the question. The rest of those, like I said, diminishing returns on memorizing the category. So back to the outline here, we talked about the different ways to categorize amino acids. First were the hydrophobic versus hydrophilic categories. The hydrophobic ones, remember, we had aromatic, aliphatic, and branched chain. And then for the hydrophilic amino acids, we had our uncharged, and then our acidic and our basic amino acids. Our next category grouping were the essential versus the non-essential amino acids. Remember, the essential amino acids had to be consumed and could not be synthesized. We had our Private Tim Hall mnemonic to help us remember those, with the understanding that these 2 were conditionally essential in times of stress. That was compared to all of the rest of the amino acids, which were non-essential. And the rest of this little note here is just that cysteine and tyrosine can be synthesized from essential amino acids. So the synthesis of those 2 is dependent on essential amino acid intake, but they themselves are not essential, if that makes sense, because you can make them within your body. And then our final category was glucogenic versus ketogenic versus mixed. The glucogenic amino acids could be metabolized into pyruvate or TCA cycle intermediates and participate in things like the TCA cycle or gluconeogenesis. Remember, you're sort of thinking the carbohydrate category of biochemistry reactions. The ketogenic amino acids were metabolized into acetyl-CoA and would participate in things like ketone synthesis, fatty acid synthesis, as well as the TCA cycle. So our lipid cluster of biochemistry reactions. And remember, all the ones in purple over here were mixed and could participate in both glucogenic and ketogenic reactions. However, it's important to know that lysine and leucine are the only purely ketogenic amino acids. All right, so let's talk about some reactions that can happen with amino acids. We're going to take a very broad view of these, just sort of define some terms that we're going to talk about later on in the chapter. The first is transamination. Transamination is the transfer of an amino group, like the ones we were talking about up here, to an alpha keto acid. And an alpha keto acid is just an amino acid without the amino group. So it just looks like this. So a transamination reaction gives a sort of naked alpha keto acid, its amino group, and turns it into an amino acid. And it's doing this either for breakdown reactions or else for the formation of non-essential amino acids, building those non-essential amino acids that we can synthesize in our body. These transamination reactions are mediated by transaminases, enzymes like AST or ALT, and we're going to talk about those at the end of the chapter. For now, just know the word transaminase and what it does. And the activity of these transaminases are mediated by pyridoxal phosphate, or PLP, which is a derivative of vitamin B6. So it is very important to know that vitamin B6 is very closely associated with these transamination reactions. Our next reaction would be a deamination, which would be removing the amino group off of an amino acid and releasing it as ammonia, versus a decarboxylation reaction, which would be releasing the carboxyl group off, and that also is mediated by PLP, the vitamin B6 derivative. All right, let's wrap it up by talking about protein structure. And we classify protein structure as primary, secondary, tertiary, and quaternary. Primary structure is going to be the one-dimensional amino acid sequence code. So this will probably be backwards on my camera here, but you can see, right, if we just had a list of all of the amino acids, if we just wrote it out in text, the order of those amino acids is the primary sequence. All right, the secondary structure is we're going to give this a linear pattern, either an alpha helix or a beta sheet. So an alpha helix would kind of be like this if we took our amino acid linear sequence and just twisted it up so it's still linear, but it's in a helix. Or you can have a beta sheet where you basically fold the linear sequence back and forth into this sort of zigzag configuration. So that's our secondary structures, either the alpha helix or the beta sheet. The tertiary structure is going to be a three-dimensional configuration, and that's going to come about by side chain interactions between the different amino acids. So little interactions like H bonding, hydrophobic interactions, disulfide bonds, all the different R groups on the different amino acids are going to make this 2D shape continue to twist around, and different amino acids are going to want to participate and interact with different other amino acids, and now you've got this 3D shape. And then if I were to make more of these, which I didn't, then we could demonstrate the quaternary structure, where if I had a bunch of these, we could show all of those interacting. Those are interpeptide interactions within a multimer. And so proteins can also lose their structure through a process called denaturation. So changes in temperature, changes in pH, or chemical reactions can weaken the bonds between these amino acids and cause the proteins to denature or lose their three-dimensional shape. If we disrupt the weak bonds in between those amino acids that were holding that structure together, then that protein can lose its secondary, tertiary, quaternary structure. So let's wrap things up. We've been talking about proteins. We learned about the building blocks of proteins, which were amino acids. We learned about the structure of amino acids and how they could come together to form peptide bonds to make amino acid chains called peptides, or if they were longer, full proteins. Every amino acid has a variable side chain, or R group, that makes it unique. There are 21 proteinogenic amino acids in the body. However, really, for the purposes of step 1, at the time I'm filming this, there are 20. We could categorize those in a couple of different ways: hydrophobic versus hydrophilic, essential versus non-essential, or glucogenic versus ketogenic, or both. We talked about different reactions that can happen: transamination, deamination, and decarboxylation. We finished off with a little discussion on protein structure, the primary, secondary, tertiary, and quaternary structure that makes up the final folded protein. And that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige, and thank you so much for joining me for our lesson on protein digestion and absorption. This video, we're going to be walking through this big diagram here, which I promise isn't so scary once we get into it. Basically just showing what happens after we take in protein in our diet. How does it get broken down in the intestine and then absorbed? And the broad overview of this is that proteins, once we eat them, are going to be denatured in the stomach by that stomach acid, as well as cleaved into peptide chains. Remember, a long protein is made up of multiple peptide chains. We can cleave down those peptides even further in the duodenum, and we'll cleave them down into oligopeptides, which are just even shorter peptides, as well as individual amino acids, the final smallest building block. Then it will be ready to be absorbed into the enterocyte, right into the intestinal cell, and it'll get taken into the portal vein and head to the liver. All right, so here's our diagram of what's going on. We've got the stomach up here, And then this is going to be the intestine. So here's the lumen of the small intestine, and then here is the enterocyte or the intestinal cell. This up here is the pancreas, and you can see the pancreas secreting its pancreatic enzymes into the lumen of the intestine. And then over here we've got the bloodstream, which will include the portal vein. All right, so here is the stomach, and here are the proteins we just took in when we ate a big protein-rich meal. Now, the stomach is full of gastric acid, and this acidic environment is very important for denaturing these dietary proteins. So in the last video, I talked to you about primary, secondary, tertiary, quaternary structure of proteins, and we sort of had our crumpled up piece of paper showing the secondary, tertiary, quaternary structure of a protein. The gastric acid is going to facilitate the denaturation of that protein, and so it's going to get rid of the secondary, tertiary, and quaternary structure, just leaving you with the amino acid chain. So it'll unfold and untangle the protein and just sort of leave it as a linear chain of amino acids. That's not the only thing this gastric acid is going to do. The other thing that gastric acid is going to do is it is going to activate an enzyme called pepsin. So at baseline, pepsin is an enzyme that exists in an inactivated form. We call the inactivated form of that enzyme, sort of that latent form, we call that a zymogen. And so moving forward for the rest of this lesson, anything that you see that ends in ogen is going to be a zymogen, and that is inactive. What the gastric acid in the stomach is going to do is it is going to activate the pepsinogen to the active form, which is just pepsin. And again, semantically for the rest of this lesson, the active form of a zymogen is just going to be the name of the zymogen minus the ogen suffix. So when we ate our meal, we had a big surge of gastric acid, and that activated the pepsinogen into pepsin. And pepsin is going to take our denatured protein, right, our linear protein, and cleave it up into peptide chains. And all these different chains are going to look different. It'll cleave at phenylalanine, tyrosine, and leucine bonds and leave you with a bunch of heterogeneous denatured peptides. Those were these. And so those are the steps that happen in the stomach. So let's go back to the outline. We had our gastric acid that denatured the ingested protein into a linear protein chain. And that gastric acid also activated that pepsinogen zymogen, right, that inactive precursor pepsinogen, into the active form, which was called pepsin. And the pepsin went on to cleave that denatured protein chain at the phenylalanine, tyrosine, and leucine bonds to form those heterogeneous peptide chains. All right, so now we're going to talk about what happens in the small intestine, in the duodenum. So we've got our peptide chains in the duodenum, but these are still too long to be absorbed. So enzymes called proteases, right, either pancreatic proteases or intestinal proteases, are going to continue to cleave up these peptide chains even more. They'll cleave them into shorter oligopeptides, and then eventually we'll get all the way down to the level of just the individual amino acid. Those shorter oligopeptides and those individual amino acids are small enough that they can get absorbed into the intestine. All right, so we followed our denatured peptides from the stomach into the intestine. That's where we are now. And we know that they're going to be acted upon by proteases to break them down even further to where we can eventually absorb them. And there are two big categories of proteases. These are the exopeptidases and the endopeptidases. And the word prefixes are going to tell you what they do. So an exopeptidase is going to cleave the outside of an amino acid chain, and an endopeptidase is going to cleave the middle. So if this is our denatured peptide, an exopeptidase would start pulling from the outside of the chain, whereas an endopeptidase would take chunks out of the middle. So let's start by talking about those endopeptidases, which are going to liberate oligopeptides out of the middle of those denatured proteins. And this whole endopeptidase pathway is going to be anchored around this enzyme right here, trypsin. So you remember how we were talking about zymogens, the inactive form of different enzymes. Trypsinogen is a zymogen for trypsin. Trypsinogen is going to be the first endopeptidase that is activated out of its zymogen form into its active form of trypsin. It's going to be activated by this enzyme enteropeptidase. Once trypsin is activated, it is going to go on and activate all of the other endopeptidase and exopeptidase zymogens. So other endopeptidase zymogens include chymotrypsinogen, which will be activated into chymotrypsin, proelastase, which will be activated into elastase. And I apologize, that is the exception to the semantic rule of the ogen suffix. Proelastase is the zymogen for elastase. And trypsin is also going to go ahead and activate more trypsinogen, making more trypsin. So once a little bit of trypsin has been activated from trypsinogen, trypsin can keep reactivating its own zymogen, and so it'll sort of cascade down quickly, and all the trypsin will be activated. Trypsin also helps activate procarboxypeptidase into carboxypeptidase. And we'll talk about that in a minute because that's actually an exopeptidase. It doesn't really belong over here with the rest of them. So all that is to say, trypsinogen was activated by enteropeptidase into trypsin. Trypsin was able to activate all the other endo and exopeptidases into their active forms to help cleave those denatured peptides into oligopeptides. Let's go talk about some more of the specifics of what some of these endopeptidases do, and then we'll come back to the diagram and we'll revisit that exopeptidase pathway. So those endopeptidases, remember, are what are in charge of mid-chain cleavage of those denatured peptides. And they're going to liberate out those mid-chain oligopeptides. Endopeptidases only come from the pancreas. And remember, the star of the whole operation in the duodenum is trypsin. So trypsinogen, the inactive zymogen, is going to be activated into trypsin via the activity of enteropeptidase. Once trypsin is active, it can go ahead and activate all of those other zymogens that we talked about, right? Trypsin comes first. And then not only does trypsin activate everything else, but it also has its own endopeptidase activity. It is going to cleave the C-terminal of lysine and arginine. If you have to remember one of the endopeptidases, you're gonna wanna remember trypsin. It's like the quarterback of this whole operation. And then we just have a little note below that's saying that enteropeptidase activates trypsinogen into trypsin via proteolytic cleavage of that trypsinogen at the N-terminus. So now let's talk about some of those other endopeptidases that trypsin can go and activate. The first one is chymotrypsin. So chymotrypsinogen will be activated into chymotrypsin by trypsin. But once we have active chymotrypsin, the job of chymotrypsin is to cleave aromatic and large hydrophobic amino acids. And you can go back to the last video, our introduction to amino acids, if you need a refresher on what some examples of those might be. Another endopeptidase activated by trypsin is elastase. And elastase is activated from proelastase, and the job of elastase is to cleave peptide bonds. And then we've got one more example of endopeptidases that we haven't seen on the diagram yet. Those are oligopeptidases. Those are located on the intestinal mucosa, and let's go over to the diagram. So once those endopeptidases have broken down those denatured peptides into oligopeptides, another endopeptidase that exists is this oligopeptidase right here on the intestinal mucosa. And it has further endopeptidase activity where it will pull out even smaller di and tripeptides out from the middle of that oligopeptide. Di and tripeptides just being really short peptide chains with either 2 or 3 amino acids. So that's our last endopeptidase, which works in the middle of the chain. Those oligopeptidases, which will break up the oligopeptides into di and tripeptides. And another enzyme will finish the job from there, which we'll circle back to. All right, so those were all the endopeptidases. Now we're going to talk about the exopeptidases. And the exopeptidases, remember, were the ones that are going to start picking off amino acids from the outsides of the chain, working their way in. So the opposite of the endopeptidases, which started in the middle. And these are both pancreatic and intestinal, in juxtaposition to the endopeptidases, which were pancreatic only. The two we're going to start by talking about are carboxypeptidase A and B. Remember, we got the sneak preview of these kind of over on the other side of the diagram here. These are exopeptidases. They were just shown on that side because you can see procarboxypeptidase is activated into carboxypeptidase by trypsin. But once those are active, those are acting as exopeptidases, and they're going to free out amino acids. And carboxypeptidases free out C-terminal amino acids. So from the end with the carboxylic acid. All right, another exopeptidase is called aminopeptidase. So remember, once the endopeptidases did their thing, they freed out oligopeptides. Aminopeptidase is going to cleave from the N-terminal of those oligopeptides and free out amino acids. So while oligopeptidase was an endopeptidase and was sort of operating from the middle, at the same time, aminopeptidase is going to start chewing its way down the N-terminal from the outside of the chain. And then we have one more exopeptidase we can talk about, which I alluded to earlier, that breaks down the di and tripeptides liberated by oligopeptidase, called either dipeptidase or tripeptidase, depending on if it's acting on a dipeptide or a tripeptide. And that'll break down those teeny tiny chains finally into their amino acid building blocks. So once these endo and exopeptidases are done with all of their activity, we're going to have some di and tripeptides and some amino acids. And those two are the units that are small enough to be absorbed into the intestine. So let's go back to the outline and recap a little bit, and then we'll talk about absorption. We've been talking about exopeptidases, which cleave from the terminal ends of peptides. We had carboxypeptidases, which were pancreatic, and there's carboxypeptidase A and carboxypeptidase B, which I'll tell you about in a second. But we had our procarboxypeptidases, those carboxypeptidase zymogens, the inactive ones, that were activated into carboxypeptidases via trypsin. And the job of the carboxypeptidases was to cleave the amino acids at the C-terminal of the chain. Like I said, there's carboxypeptidase A and carboxypeptidase B. Super easy to remember. Carboxypeptidase A cleaves aromatic amino acids. Carboxypeptidase B cleaves basic amino acids. Either way, they're both operating at that C-terminal. Contrast that with the activity of aminopeptidase and intestinal exopeptidase, which cleaves N-terminal amino acids. Doesn't matter which, it'll just start chomping away at the N-terminal of the oligopeptide. And then finally, we had dipeptidase or tripeptidase, which is intestinal, and that cleaves dipeptides or tripeptides. All right, the hard part is done, okay? Remember, we've got di and tripeptides, and we've got amino acids, and they are ready to be absorbed. The amino acids are going in to the enterocyte via these pumps right here. And I don't want to get too in the weeds about the specifics here. This is a little lower yield. The short of it is they get absorbed, all right? But if you want to be specific, it's a little different between the basic amino acids, the neutral amino acids, and the acidic amino acids. Neutral and acidic amino acids are going to enter the enterocyte via sodium-coupled channels. So you can see here how sodium is coming in along with it. If you see over here in the diagram, we have a sodium-potassium pump, our favorite staple of biochemistry, that is actively using ATP to push sodium out of the enterocyte. Since we're pushing sodium out of the enterocyte over here by the activity of this pump, we have sort of a sodium vacuum here inside the enterocyte since we're pushing all of it out. Since we have that sodium vacuum, sodium's going to want to come rushing in from the lumen of the intestine, and we can use that rush in and that power from the vacuum to bring in these neutral and acidic amino acids. The basic amino acids work a little differently. If this confuses you, please don't spend too much time on it. But the basic amino acids don't use sodium. They're going to trade a neutral amino acid that has already been brought in via its pump. They'll trade that back out. They'll sacrifice it to bring in that basic amino acid. And the neutral amino acid can just go back in the channel powered by sodium. So the neutral and acidic amino acids are powered by sodium. The basic amino acid is powered in the opposite direction by the neutral amino acids, which can then go back in and be sodium powered again. It's just happening because the basic amino acids can't use the power of sodium, so it's sort of a middleman workaround. All right, so that was the absorption of amino acids. The absorption of di and tripeptides is going to be coupled with proton transport in through this PEP-T1 proton symporter. And then once those di and tripeptides are in, they can be acted upon by that di and tripeptidase, the same one from over here that was operating in the lumen, now just operating in the enterocyte, break those di and tripeptides into amino acids. And now everything is just broken up into amino acids inside the enterocyte, can be absorbed into the bloodstream and go via the portal vein to the liver. So we had our amino acids that could go into the enterocyte via the sodium-coupled carriers, which was sort of powered by the sodium vacuum from the sodium-potassium pump. Those amino acids could be exported to the blood via basolateral transporters, go to the portal vein, go to the liver. The other option was for those di and tripeptides to be absorbed first via that PEP-T1 proton symporter, then get broken down via di and tripeptidases into amino acids, and then those could get absorbed. So let's wrap this up. We've been talking about how we go from fully formed proteins into denatured proteins, into denatured peptides, into oligopeptides, into di and tripeptides, into amino acids. Our proteins were first denatured into the stomach, into those linear proteins without secondary, tertiary, quaternary structure. Our proteins were first denatured out of their secondary, tertiary, quaternary structure via gastric acid. And then those denatured proteins were cleaved by pepsin into different shorter peptide chains. Those peptide chains were cleaved even shorter by endo and exopeptidases in the lumen of the intestine. Those could either come from the pancreas or from the intestine. And like I said, the quarterback of the duodenal enzymes is going to be this trypsin here. The trypsinogen zymogen is activated into trypsin, and trypsin goes on and activates all of the other zymogens into their active forms. So we've got trypsin, chymotrypsin, elastase, and oligopeptidases all operating to cleave out oligopeptides from the middle of peptide chains. And then we have exopeptidases like the carboxypeptidases and aminopeptidases and even di and tripeptidases, which are cleaving from the outside. And we're getting those peptides smaller and smaller and smaller until they're in their individual amino acid building blocks, which can be absorbed into the enterocyte and into the blood and go off to the liver. And that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on phenylalanine, tyrosine, and catecholamines. In this lesson, we're going to be talking about the breakdown of phenylalanine, which is an essential amino acid. Phenylalanine gets metabolized into a ton of different products, and the whole tree of the breakdown products of phenylalanine is especially high yield for the Step 1 exam. And that's because there are a bunch of disorders that stem from problems in this metabolic pathway that we'll talk about a little bit in this video and then a lot more in depth in the next video. Broadly, phenylalanine gets broken down into tyrosine, and then tyrosine can either go and join the TCA cycle or it can be broken down through another pathway involving dopamine and catecholamines. Catecholamines, remember, are a family of neurotransmitters that are aromatic amines, and they include epinephrine and norepinephrine, so very important to know. And exciting that we can talk about them today. All right, so here's our diagram of phenylalanine breakdown. We've got phenylalanine over here on the left, and you can see the two pathways we talked about. We've got the TCA cycle pathway, and we have the dopamine and catecholamine pathway, which is this whole mess over here. Like we said, the first step in phenylalanine breakdown is the breakdown of phenylalanine into tyrosine via enzyme 1 here, which is phenylalanine hydroxylase. And the cofactor for phenylalanine hydroxylase is something called tetrahydrobiopterin, or BH4. So this BH4 is a cofactor for PAH, and as it facilitates that reaction, the BH4 is going to get turned into BH2, also known as dihydrobiopterin, BH2. Because that BH4 is critical for the function of phenylalanine hydroxylase, that enzyme that's mediating that step here, we have to make sure that we have a way to replenish that BH4 cofactor from the BH2 byproduct of this reaction. And there's an enzyme called dihydropteridine reductase, or DHPR, that is going to facilitate the reformation of BH4 from BH2. It'll reduce the BH2 back to BH4. As you can see, BH4 is used in a couple of other reactions across the diagram, including tryptophan breakdown. Don't worry about this tryptophan stuff for now. We're going to cover this in a future video, okay? It'll come back. So back to the outline. First step of phenylalanine breakdown is the breakdown of phenylalanine to tyrosine via that PAH enzyme, phenylalanine hydroxylase. And remember that PAH had a cofactor BH4. That BH4 was oxidized into BH2 as that PAH reaction proceeded. So we had that enzyme DHPR, which could replenish that BH4 stock and made sure that BH4 was available for the phenylalanine hydroxylase reaction. So as you can see, both phenylalanine hydroxylase and BH4 are important for that first step of phenylalanine breakdown. A disorder in this step is called phenylketonuria, or PKU. The classic form of phenylketonuria involves a deficiency in that PAH enzyme. However, you can also get phenylketonuria, a different type called malignant PKU, if there's a deficiency in that DHPR enzyme. In either case of phenylketonuria, you are not getting this first step in the phenylalanine breakdown pathway where phenylalanine turns into tyrosine. And we'll talk more about those disorders in the next videos on the clinical implications of phenylalanine breakdown. All right, so once we have our tyrosine, that's where we split either into our TCA cycle pathway or our dopamine and catecholamine pathway. Let's talk first about the TCA cycle pathway. In the TCA cycle pathway, this tyrosine that we made is going to go through a series of steps that are not so important to know the details of and form homogentisate, also known as homogentisic acid. However, the next step is important to know, and that's this reaction in which homogentisate turns into mallyl acetoacetate via enzyme 9 here, homogentisate oxidase. Then mallyl acetoacetate can go on to form fumarate, which is an intermediate in the TCA cycle. So we talked about how in the TCA cycle pathway, tyrosine goes through a series of steps to become homogentisic acid or homogentisate. The homogentisic acid becomes mallyl acetoacetic acid or mallyl acetoacetate via that enzyme homogentisate oxidase. And that enzyme is important because a deficiency in that enzyme causes another disorder called Alkaptonuria. And that's another one we'll talk about in the next video. Alkaptonuria being a deficiency of homogentisate oxidase. Once we've made our mallyl acetoacetate, we can turn that into fumarate, which is a TCA cycle intermediate. We can run the TCA cycle that we are so familiar with by now. All right, so that was the TCA cycle pathway. Now we're going to talk about the dopamine pathway. So we'll take the other branch point off of tyrosine. The first step will be turning tyrosine into something called DOPA, which stands for dihydroxyphenylalanine. The enzyme that mediates that is enzyme 2 here, tyrosine hydroxylase. And it also has a cofactor of that same BH4 that we talked about that helped facilitate the PAH reaction. So just like before, we'll use that BH4 as a cofactor for tyrosine hydroxylase this time, and then we can replenish it with that DHPR enzyme. And unfortunately, this reaction tree is about to keep splitting and splitting and splitting, so bear with me. DOPA can become one of two things. The first thing it can be broken down into is melanin via enzyme 3 here, which is called tyrosinase. Melanin is your skin pigment, so the darker your skin is, the more melanin you have. So if you have a defect in the enzyme tyrosinase, that is how you get albinism, which is a condition characterized by a lack of pigmentation. We'll talk about that in the next video too. So that's one thing DOPA can become. Or DOPA can go down the whole rest of this pathway, starting with the next step, turning DOPA into dopamine via the enzyme 4 here, DOPA decarboxylase, which has a vitamin B6 cofactor. And now our tree splits again, and we can either break down dopamine or let it proceed on down the tree. The breakdown pathway of dopamine will result in the production of homovanillic acid. All right, so that's if we break down our dopamine. Or we can turn our dopamine into catecholamines like norepinephrine and epinephrine. So to turn dopamine first into norepinephrine, we're going to use enzyme 5 here called dopamine beta hydroxylase and use vitamin C as a cofactor for that step. And that'll form norepinephrine, one of our catecholamines. And then to turn norepinephrine into epinephrine, another one of our catecholamines, we'll use enzyme 6 here, phenylethanolamine N-methyltransferase. And the cofactor for that enzyme is going to be our friend SAM from the activated methyl group cycle, which we talked about in our chapter on 1-carbon metabolism. So there's SAM, always nice to run into an old friend. And that enzyme 6, phenylethanolamine N-methyltransferase, is also upregulated by cortisol. That makes sense. In times of stress, you're going to be ramping up your production of epinephrine. All right, so we've made our catecholamines norepinephrine and epinephrine. Just like how we talked about the breakdown of dopamine, we can talk about the breakdown of these catecholamines. The breakdown pathways of the catecholamines kind of run in parallel to one another. So norepinephrine is going to be broken down into first a product called normetanephrine, and epinephrine is going to be broken down into metanephrine. So epinephrine to metanephrine, norepinephrine to normetanephrine. The enzyme that mediates both of those reactions is the same, enzyme 7, called catechol O-methyltransferase, abbreviated to COMT or COMT. All right, and then both normetanephrine and metanephrine can finally reach their ultimate breakdown product called vanillyl mandelic acid. So a little confusing, sounds the same, but not the same as the homovanillic acid. Vanillyl mandelic acid comes from the breakdown of catecholamines. And that is mediated by enzyme 8 here, monoamine oxidase. All right, so back to the outline to talk about the dopamine and catecholamine pathway of phenylalanine breakdown. Remember, our branch point was with tyrosine. That tyrosine was broken down into dopa via tyrosine hydroxylase with that tetrahydrobiopterin cofactor, that BH4 cofactor. We could turn that dopa into melanin via tyrosinase. And remember, a deficiency in that tyrosinase activity was what led to albinism. Or if we didn't want to go down that pathway, we could turn that dopa into dopamine via the enzyme dopa decarboxylase, which has a cofactor of vitamin B6. For clinical implications, there's a very famous drug called carbidopa, which inhibits that dopa decarboxylase enzyme. And I'll add that to the diagram for you here. That's a medication that treats Parkinson's disease. The next step down the pathway is turning dopamine into norepinephrine via the enzyme dopamine beta hydroxylase, which had vitamin C as a cofactor. And then that norepinephrine could turn into epinephrine via that enzyme phenylethanolamine N-methyltransferase. That one had our friend SAM as our cofactor, our methyl group carrier, and it was upregulated by cortisol. So we could turn norepinephrine into epinephrine, or we could break down that norepinephrine and turn it into normetanephrine via that COMT enzyme. Similarly, epinephrine could be broken down into metanephrine via that same COMT enzyme. Those were our parallel breakdown pathways of catecholamines. And then continuing down those parallel breakdown pathways, normetanephrine and metanephrine both get broken down into vanillyl mandelic acid via that enzyme monoamine oxidase, or MAO. And then that one other breakdown pathway that we haven't talked about yet in our recap was dopamine, and that instead of dopamine continuing down to form catecholamines, it could be broken down into homovanillic acid. The reason that I'm kind of circling back to that one now is that metanephrine's vanillyl mandelic acid and homovanillic acid are all things that can be measured in a condition called pheochromocytoma. So a pheochromocytoma, or a pheo, is a neuroendocrine tumor of the chromaffin cells of the adrenal glands. So this is a type of tumor that is going to secrete catecholamines. More catecholamines means more catecholamines to break down, which means more of these catecholamine breakdown products. Practically, serum metanephrines are the ones that are most commonly measured. However, it's not off limits for the STEP exam to also ask you about VMA and even HVA. HVA because these pheos can also secrete dopamine. So while elevated serum metanephrines in pheochromocytoma is the most common practical test question, don't be surprised if you see any or all of these. And you can learn all about pheochromocytoma in the endocrine unit. Finally, I'll just tell you one other clinical implication about this last set of steps here. That's a type of drug called MAO inhibitors. Remember, MAO was monoamine oxidase. MAO inhibitors are usually used as atypical antidepressants, and they've fallen out of favor because of their side effect profile, but they are still used. And the theory behind them comes from something called the monoamine hypothesis. So norepinephrine, dopamine, and serotonin are all what are called monoamines. And the monoamine hypothesis states that low monoamines are associated with depression. So MAO inhibitors cause an increase in these monoamines by preventing them from being broken down by that monoamine oxidase. And as such, they can be used in depression. And you can learn more about MAO inhibitors in the psychiatry unit. So let's wrap this up. We've been talking about the breakdown of phenylalanine via two major pathways, the TCA cycle pathway and the dopamine and catecholamine pathway. Both pathways start the same way with the breakdown of phenylalanine into tyrosine via the enzyme phenylalanine hydroxylase. This step had a cofactor of tetrahydrobiopterin. Deficiencies either in the enzyme itself or in the cofactor led to a condition called phenylketonuria, or PKU. Once we had our tyrosine, that was where our pathways split off. For our TCA cycle pathway, we could break that tyrosine down into homogentisic acid, then into mallyl acetoacetic acid via the enzyme homogentisate oxidase. Deficiency there caused the disorder Alkaptonuria. In the dopamine and catecholamine pathway, we could turn tyrosine into dopa via tyrosine hydroxylase. Dopa could either turn into melanin or dopamine. We talked about some of the clinical implications for each of those branches in our pathway. Dopamine could be broken down into norepinephrine and then to epinephrine. We talked about a couple of clinical implications like MAO inhibitors and serum metanephrines and carbidopa that are covered elsewhere by other people in other units. But if you stick with me, we'll talk next about some of those clinical implications that we started to talk about, including PKU, Alkaptonuria, and albinism coming up next. So stay tuned. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on the clinical implications of phenylalanine metabolism. In the last video, we talked about the breakdown pathways of the amino acid phenylalanine. Remember, the first step of phenylalanine breakdown was the conversion of phenylalanine into tyrosine via the enzyme phenylalanine hydroxylase. And you can see that step here, phenylalanine turning into tyrosine via the enzyme phenylalanine hydroxylase, an enzyme which required a cofactor called tetrahydrobiopterin, or BH4. Once we had formed tyrosine, we could split into two pathways. The first is the TCA cycle pathway, which notably included enzyme 9 over here, homogentisate oxidase. Or our other branch point from tyrosine was this dopamine and catecholamine pathway. One enzyme I'll draw your attention to for the sake of this video over here in that branch point is enzyme 3 here, which is tyrosinase, which turns dopa into melanin. So tyrosine could either go to the TCA cycle via homogentisate oxidase, or it could participate in the dopamine and catecholamine pathway. One of the enzymes in that pathway was called tyrosinase. And so we're going to talk about these three enzymes, this phenylalanine hydroxylase, this homogentisate oxidase, and this tyrosinase. Deficiencies in these enzymes can lead to various inborn errors of amino acid metabolism. And obviously the presentation is going to depend on which enzyme is involved. So let's get into it. First condition we're going to talk about is called phenylketonuria, or PKU. Phenylketonuria is a condition where the conversion step from phenylalanine to tyrosine is inhibited. And we can see the inhibition of that step in a couple of different ways. The classic form of phenylketonuria is a deficiency in PAH, right? We properly just knock out the enzyme. We can't convert phenylalanine into tyrosine. But there's another way to knock out that step. Remember, PAH requires tetrahydrobiopterin, or BH4, as a cofactor. So if we have a deficiency of BH4, we will also knock out that conversion of phenylalanine to tyrosine. We discussed BH4 is replenished by the activity of this enzyme here, dihydropteridine reductase, DHPR. So there's another type of PKU called malignant PKU, which is characterized by a deficiency in the DHPR enzyme. The result of that deficiency means that there's not enough BH4 to act as a cofactor for that step. So two different ways to go about knocking out the same conversion step. Classic PKU is a deficiency in the PAH gene, which results in a decrease in the conversion of phenylalanine to tyrosine. As such, you'll get a buildup of that phenylalanine upstream and a decrease in tyrosine, right, because we can't form it from the phenylalanine. And what this does is this turns tyrosine into an essential amino acid. We touched on this for a second in our Introduction to Proteins video, but normally your body can make tyrosine from phenylalanine. So tyrosine itself is not an essential amino acid under normal circumstances, as long as you have enough phenylalanine, which is the essential amino acid. That being said, when we knock out this step, we turn tyrosine into an essential amino acid because it cannot be synthesized in the body anymore. And if we have no tyrosine, we don't have either of these downstream pathways running. So we're going to have a decrease in our downstream neurotransmitters, right, like dopamine. We're also going to have a decrease in our melanin production, which was also downstream. So that was classic PKU, a PAH deficiency. But remember, we also had malignant PKU, which was a deficiency in that BH4, remember, from having the DHPR enzyme deficiency. So here you're going to see an increase in phenylalanine and a decrease in tyrosine, just like before. However, you're also going to see a decrease in serotonin production. And we'll talk about this pathway involving tryptophan and serotonin in a future video. But for now, just understand that BH4 is also a cofactor for the production of serotonin from tryptophan. So if we knock out that step, we're going to get a decrease in serotonin as well. So that's what's a little different about malignant PKU, but largely malignant and classic PKU are clinically indistinguishable from one another. So you'll have to rely on labs to differentiate them, and we'll talk about that in a minute. Let's talk first about the clinical presentation, which is going to be the same between malignant and classic PKU. This is a high-yield clinical presentation to know. They love to talk about the musty odor of patients with PKU. It's one of those things where you'll be reading the vignette and they'll make this out-of-pocket comment about how the patient smells, and in your head you're like, was that really necessary? But that odor should be a part of your illness script for PKU. That's because phenylalanine is an aromatic amino acid, and they're not called aromatic for no reason. They do put out an aroma. So the buildup of that phenylalanine, that aromatic amino acid, will in fact make the patient smell. Musty is typically how they describe it. Additionally, like we said, we're going to have decreased melanin production, which is going to result in a fair complexion and fair hair and blue eyes. So down here, you can see an example of a patient with PKU, and you can see she has a fair complexion, she has blonde hair. You can't really see her blue eyes here. And then the other thing you can see sort of on her face is she has some eczema, another common finding for patients with PKU. And then some other clinical sequelae of the buildup of that phenylalanine and the decrease of the downstream neurotransmitters include seizures, decreased growth, psychomotor delay, and hypertonia. Like I said, that will be the clinical presentation for patients both with classic and malignant PKU. So how do you tell them apart? The first thing you're going to do, just to know if you're dealing with any category of PKU, is you're going to do a newborn screen. So a newborn PKU screen, they'll do a heel stick. They'll get a blood sample, and in the blood sample, they will see elevated serum phenylalanine. So that tells us we have PKU, but we don't know what type of PKU we have. To differentiate classic from malignant, we're going to do an oral BH4 loading. So what the oral BH4 loading is going to tell us is whether or not the patient's problem resolves when you give them BH4. If the built-up phenylalanine goes down with the administration of BH4, you know that the problem is a deficiency in BH4, the cofactor, and that is malignant PKU. All right, if it doesn't get better when you give the cofactor, then you know that it's a problem with the enzyme itself, that it's a deficiency in PAH, and that is a classic PKU. In both types of PKU, you'll also see an elevation in urine phenylketones. All right, so how are we going to manage PKU? For all patients, regardless of the subtype of PKU that they have, you're going to give them dietary tyrosine, and you're going to decrease their intake of phenylalanine as well as aspartame. So remember, tyrosine is now an essential amino acid, so we have to supplement that directly, and that'll help bypass this busted step here. And by the same logic, we're going to decrease the amount of phenylalanine that these patients take in so that we don't get that buildup before the blocked step. Aspartame, if you weren't aware, is an artificial sweetener in a lot of diet sodas. And aspartame contains phenylalanine. And so on a lot of these drink cans, you can actually see a warning label that's printed that says phenylketonurics contains phenylalanine. So practically on a test question, the answer choice might be to avoid artificial sweeteners, and that would be why. So all the changes we just discussed hold true for both types of PKU. However, if you just give tyrosine to a patient who has a deficiency in DHPR and BH4, they're still not going to be able to use that tyrosine because remember, the next step in tyrosine breakdown, mediated by enzyme 2 tyrosine hydroxylase, that step also requires BH4 and therefore also requires the activity of DHPR. So if you give tyrosine to a patient with malignant PKU, it's still not going to be enough. You have to also supplement BH4 in those patients so that they can use the tyrosine that you're giving them. Other things that you can give patients with malignant PKU are levodopa and hydroxytryptophan. And these are precursors to dopamine and serotonin that can help to boost the production of those neurotransmitters. Again, though, really the key thing that you have to make sure you do is supplement that BH4. That's why it's called malignant PKU, is it's the type of PKU that doesn't respond just to the standard treatment. It requires that extra push. All right, so let's do a clinical vignette for a patient with PKU. Let's say we have a 6-month-old boy who's brought to the pediatrician by his concerned parents due to some developmental delays. They're saying that the child is not maintaining eye contact, is not showing interest in toys, and is exhibiting some delayed motor milestones. They might even do a physical exam section where they describe some of the behaviors of the child and you have to determine if it's an age-appropriate milestone or not. Although that's really more of a step 2 in PEDS shelf question. Just something to be aware of sort of for the next step. The parents also say that the child has a musty odor in his urine when they change his diapers. On physical exam, the child has blonde hair, blue eyes, fair skin, and the neuro exam is showing hypertonia and hyperreflexia. They also say the child is not yet sitting without support. So right there might be an example of something where they would want you to know whether that was normal or abnormal for a 6-month-old. And then when we do a lab workup, we see elevated blood phenylalanine level. From an elevated blood phenylalanine level, Can we tell whether the child has classic or malignant PKU? The answer is no. And so what would your next step be to try and figure out what type of PKU this child has? You would do an oral BH4 loading test. All right, so we're done talking about PKU. Let's move on and let's talk about Alkaptonuria. Remember, from tyrosine, one of the pathways we can take is this TCA cycle pathway. One of the enzymes in this pathway is enzyme 9 here, homogentisate oxidase. A deficiency in homogentisate oxidase is called Alkaptonuria, and a deficiency in that enzyme is going to cause decreased conversion of homogentisate into mallyl acetoacetate, and that means you'll get a buildup upstream of homogentisate and tyrosine. Back to the outline, like we said, Alkaptonuria is a deficiency in the homogentisate oxidase gene, which causes a decrease in the conversion of homogentisate or homogentisic acid, same thing, to mallyl acetoacetate, also known as mallyl acetoacetic acid, and this causes a buildup upstream of homogentisate and tyrosine. The buildup of this homogentisate is going to cause a very interesting clinical presentation. It's called ochronosis, and it is a blue-black discoloration of body fluids and connective tissue. So you can see down here in this child, there's discoloration, a blue-black discoloration around the mouth. That's called ochronosis. It's from the buildup of the homogentisate, in this case in the dermis, and it's called ochronosis because the color ochre is actually a yellow color, and that's what you'll see on histology due to the deposition of the homogentisic acid. And then the other big thing you'll see is systemic calcification, and this can present in a couple of different ways. You can get calcification in the form of kidney stones or nephrolithiasis. You can get calcification of valves like mitral valve stenosis. You can get calcification of joints that would cause arthritis. And these are all very high-yield clinical features. Again, the theme for these disorders of phenylalanine metabolism is they lean very heavily on the clinical presentation in the vignettes and making sure that you have a really strong illness script in your head locked in. To diagnose this, you can actually look at the urine. So one of the body fluids that turns blue-black is the urine. And so one of the diagnostic tests for this is a black standing urine. And that's where they literally take the urine and then they let it sit on the counter for a while and you see what color it turns. In the vignette, the patient might also say, like, if I get some pee on the toilet seat and I don't clean it right away and I come back, it'll turn black. You can see here an example of that black standing urine. The vignettes for this disorder are very image heavy, so I would lock these into memory. Besides black standing urine, you can also test the urine, as well as the serum, for an elevation in homogentisate. The management here is going to be a diet that is low in tyrosine and phenylalanine to prevent the buildup of homogentisic acid. Right, by decreasing the consumption here, we're reducing the upstream buildup of the homogentisate. And like we were saying before about phenylalanine, aspartame is still going to apply here under our low phenylalanine diet. So let's do our Alkaptonuria vignette. Let's say we've got a 35-year-old guy who's presenting to his PCP with dark discoloration of the urine. He says that it's most noticeable after the urine is exposed to air and it'll turn black. He's denying dysuria, and he has a pretty unremarkable medical history, and he's not taking any medications, so it's not because of that. We do a physical exam, and we're going to see some blue-black discoloration of actually his sclera as well as his ear cartilage. That's that ochronosis. We get a urinalysis. It shows a dark color of the urine, and then further investigation shows elevated levels of homogentisic acid. Like I was saying, with both PKU and with Alkaptonuria, this last line where they actually just give you the elevated thing on labs might not always be there. They might only give you the clinical presentation and then want you to predict what's going to be on labs. That's why you have to have those physical exam findings really dialed in for these disorders. All right, and then the last disorder we'll talk about is albinism. Albinism is a defective tyrosinase enzyme that is going to cause a decrease or an absent production of melanin. So decreased tyrosinase means a decreased conversion of tyrosine to melanin, and it means that you're going to have low melanin production, even in the setting of a normal number of melanocytes. So structurally and numerically, the melanocytes are okay. It's a defect in the enzyme to make the melanin. The presentation here is going to depend on what tissues the enzyme is affected in. So there's ocular albinism and oculocutaneous albinism. So ocular albinism is going to affect the iris and the retina only. Oculocutaneous is going to affect both of those places in the eye, as well as the skin and the hair. So the ocular manifestations of albinism are iris hypopigmentation, photophobia, a decrease in visual acuity, extraocular movement abnormalities, so things like nystagmus or strabismus, diplopia or double vision, and then optic nerve abnormalities, which feeds into the whole visual acuity picture as well. So those were the ocular manifestations, and then if the patient has cutaneous manifestations on top of that, you would see hypopigmented skin and hair, photosensitivity with an increased risk of sunburn, as well as an increased risk of skin cancer. And so here you can see an ocular manifestation. You can see some of the iris hypopigmentation here. And then here are some cutaneous manifestations. You can see this child has white hair, very pale skin, white eyebrows, white eyelashes. And it's hard to tell from this picture, but his eyes might even be slightly crossed here, showing some of the ocular symptoms as well. Diagnostic here, honestly, is fairly straightforward just to diagnose clinically, either with an ophthalmic or a dermatologic evaluation. And the management here is just supportive, basically protecting the skin and the eyes, vision support, things like that. So let's do our vignette, and this is a vignette specifically for a patient with oculocutaneous albinism. Let's say we have a 7-year-old girl who's brought into the pediatrician for a checkup, and the parents say that their daughter has always had pretty fair skin and light blonde hair and strikingly blue irises, which is confirmed on her physical exam. And then the optho exam is going to reveal nystagmus, which remember was that abnormal beating of the eyes. It's an extraocular movement abnormality, and will reveal reduced pigmentation in the retina. So let's wrap this up. We've been talking about the clinical implications of phenylalanine metabolism. The first one was phenylketonuria, or PKU, which was an inability to convert phenylalanine to tyrosine. In the classic form of PKU, that was due to a deficiency in the enzyme phenylalanine hydroxylase. In the malignant form of PKU, it was due to a decrease in that BH4 cofactor of the PAH gene due to a deficiency in DHPR. Either way, they both presented with musty odor, fair complexion, seizures, psychomotor delays, eczema, things like that. It's initially diagnosed on a newborn screen and then differentiated with an oral BH4 loading test, and it's managed by supplementing tyrosine, which becomes an essential amino acid in this condition, and reducing dietary phenylalanine, which includes aspartame. Remember, in the case of malignant PKU, however, we also had to supplement BH4 if we wanted that treatment to work. Next condition we talked about was Alkaptonuria, which was a deficiency in the enzyme homogentisate oxidase. This caused a buildup in homogentisate as well as tyrosine, and that elevated homogentisate could deposit in connective tissue as well as body fluids like urine and cause that blue-black discoloration, as well as systemic calcification, which can take on a couple of different forms. This was either diagnosed with standing urine, which would turn black, or else looking at the urine or serum homogentisate levels, managed with a low tyrosine and low phenylalanine diet. And then finally, we had albinism, which was a defect in the tyrosinase enzyme, which caused a decrease or absence in the production of melanin, even in the presence of normal melanocyte levels. Depending on the affected tissues, this could either present just in the eye or additionally in the skin. And the main feature here is hypopigmentation of the affected tissue, as well as some visual abnormalities and extraocular movement abnormalities. This was diagnosed clinically and managed supportively. And that is enough about phenylalanine. Let's talk about some new amino acids next. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige, and thank you so much for joining me for our lesson on tryptophan, niacin, and serotonin. In this video, we're going to be talking about the breakdown pathways for the amino acid tryptophan. And there are two major pathways. The first pathway is tryptophan being broken down into niacin, which is also known as vitamin B3. And that's a pathway that's taking place in the bloodstream. The other breakdown pathway for tryptophan is turning it into serotonin, and that is a pathway that is going to cross the blood-brain barrier and take place in the brain. The major products of that first pathway, that niacin pathway, are going to be NAD+ and NADP+. Remember, these are electron carriers and various metabolic processes that we've talked about so far throughout the biochemistry unit. And then the ultimate product of the serotonin pathway is going to be melatonin. So let's take each of these breakdown pathways in turn, and we'll start with the niacin pathway, which is formally known as the kynurenine pathway. So we can take a look at our image here. We're starting with tryptophan, and you can see the two different pathways. Here's the niacin pathway and then the serotonin pathway, which we'll talk about in a bit. An important disclaimer here is that in reality, the breakdown pathways of tryptophan, including this kynurenine pathway, are in fact very complicated, but for the sake of step 1, there's actually not a whole lot you need to know about it. For the niacin or the kynurenine breakdown pathway of tryptophan, we'll start by turning tryptophan into an intermediate called kynurenine, and then through a series of very complicated steps, which you don't really need to know the enzymes for, but you should know the cofactors B2 and B6, that kynurenine will turn into niacin. Remember, niacin is the same thing as vitamin B3. And so niacin, vitamin B3, is a very important intermediate in this pathway with some clinical implications that we'll talk about in a minute. But first, let's complete this pathway here. Once we've made our niacin, we can turn it into nicotinamide, which will undergo more complex reactions and eventually turn into NAD+ and NADP+. And from a pathway perspective, that's really it in terms of what you need to know. Don't get bogged down on too many enzymes. Just know the steps that are listed here on the slide and you should be in pretty good shape. Know that tryptophan turns into kynurenine, which eventually will become niacin through a series of reactions that are mediated by the cofactors vitamin B2 and vitamin B6. Once we have our niacin, if we're going to continue to break down that niacin and follow the pathway along, we'll turn the niacin into nicotinamide and eventually turn it into NAD+ or NADP+. And remember, those are electron carriers for different metabolic processes across the body. So there's the pathway, not too exciting on the surface. Let's talk a little higher order now about what you are very likely to be tested on, the clinical implication of this, which is Hartnup disease. Hartnup disease is a disease where there is a deficiency in the neutral amino acid transporter in the intestine and the renal proximal tubule. So tryptophan is a neutral amino acid that would be taken into the body through these transporters. And in Hartnup disease, we don't have these transporters. What that means is that patients with Hartnup disease have a deficiency in tryptophan. So low tryptophan in Hartnup disease will lead to decreased niacin downstream, right? No niacin synthesis without its precursor tryptophan. And that is going to lead to a very particular clinical picture with a constellation of symptoms of vitamin B3 deficiency. And this constellation of symptoms of a niacin deficiency is very specific and it's very high yield. How a vitamin B3 or a niacin deficiency presents is with something called pellagra. And you can remember pellagra by the 3 Ds: dermatitis, dementia, and diarrhea. So dementia and diarrhea should be pretty straightforward. The dermatitis has a pretty specific distribution. A big must-know finding is the C3 and C4 cape-like rash. So what I mean by C3, C4 is a rash along the C3 and C4 dermatomes. So if you don't know what a dermatome is, I encourage you to look up a dermatome map. But a dermatome is an area of skin innervated by a single nerve root. So the distribution of the C3 and C4 dermatome is kind of like a collar or a cape that comes around the back of your neck to the front here. And that is where you would see the rash. And that specific distribution is very common. And you'll also see hyperpigmentation on the face and the limbs as well in a niacin deficiency. So if there's a buzz phrase or an image you want to know for a niacin deficiency, it's going to be this one right here. You can see this cape-like rash sitting across the C3 and C4 dermatome, and you can see how it would kind of wrap to the front as well. And then over here, you can see this picture of a little girl too with a niacin deficiency. You can see her face. You can see, again, the neck rash, kind of like a collar coming around to the front, and her hands as well. Another big finding that goes along with a niacin deficiency, as you might see in Hartnup disease, is cerebellar ataxia. Issues with balance and walking might show up on the vignette as well. To diagnose this, you're going to look for the quantity of neutral amino acids in the urine. If you don't have that neutral amino acid transporter in the kidney that would normally be reabsorbing the neutral amino acids in from the urine, they're going to get excreted out in the urine if we can't reabsorb them, and that's something that we can measure. If you want to be sure of this, you can do a tryptophan loading test where you give the patient a bunch of tryptophan and then measure the urine. Management of Hartnup disease is going to be pretty straightforward. You're going to supplement niacin, as you might expect, and then the other thing we're going to do is we are going to increase dietary protein just because we are wasting so many amino acids out because we're not reabsorbing them in the gut and the kidney. So let's walk through a vignette. Let's say we've got a 12-year-old boy who's brought to the clinic by his parents because they're concerned about his health. Very helpful chief complaint. So the parents are reporting that their son has been experiencing a persistent erythematous skin rash on sun-exposed areas. It's worsening during the summer months. Okay, I don't know what to make of that, so we'll keep going. They also note episodes of confusion and unsteadiness, with the child occasionally stumbling while walking. So we have some sort of rash. We're probably just going to wait for our physical exam section to see what's up with that. We also have some ataxia. All right, physical exam. The child has a symmetric, scaly, photosensitive rash on his face, neck, and dorsum of the hands. Sometimes that's actually accompanied by a photo like the one I showed you of the rash. Neuroexam reveals mild cerebellar ataxia. With that, they might not tell you that outright. They might say something like a wide-based gait. They'll probably make you work for it a little more as opposed to giving you the buzzword. And then laboratory investigations are demonstrating amino acid urea, and a tryptophan loading test reveals increased urinary excretion of tryptophan. So they might give you that last line and ask you for the diagnosis, or they might just give you the clinical picture because it's specific enough and ask you to predict what you might see on lab findings. And you'll see that a lot across step 1. If a disease or a disorder has a very specific physical exam or clinical vignette, they might not even give you any labs. They might make you predict the labs yourself because you should already have a pretty good working diagnosis. All right, so that's enough about Hartnup disease, and that's enough about the niacin breakdown pathway of tryptophan. Now we're going to talk about the serotonin pathway. In the serotonin pathway, tryptophan, first things first, is going to cross the blood-brain barrier, and there it will undergo a series of reactions to turn into serotonin. And again, it's another complex reaction, but there are a couple of cofactors and steps that you should be aware of. First things first, you should know that tetrahydrobiopterin, or BH4, which we talked about in previous videos, is going to make a reappearance here as a cofactor for tryptophan breakdown into serotonin. As we discussed, when BH4 is used as a cofactor, it is turned into BH2, and then remember, to get that BH4 back so we can use it again in a subsequent reaction, we have to reduce that BH2 via the enzyme DHPR, dihydropteridine reductase. So that was one reaction. And then the next reaction is going to be facilitated by the enzyme AADC, which stands for aromatic L-amino acid decarboxylase. And this is going to require a vitamin B6 cofactor. And then we've got our serotonin. Something that is semantically so annoying, as is the case across biochemistry, AADC has another name, and its other name is something that you've encountered before when we learned about the breakdown pathways of phenylalanine. This enzyme 4 here, dopa decarboxylase, which breaks down dopa into dopamine, that dopa decarboxylase enzyme is the same enzyme as AADC. It just has another name, and I don't know why. So tryptophan crossed the blood-brain barrier, and through a series of reactions turned into serotonin, those reactions requiring tetrahydrobiopterin, or BH4, as well as vitamin B6 as cofactors. And that second step was mediated by AADC, which stood for aromatic L-amino acid decarboxylase. And serotonin in the body is in charge of mood, behavior, cognition, digestion, pain, vasoconstriction. So tons of clinical implications of serotonin and therefore of this pathway. So tryptophan turned into serotonin, and now serotonin can be broken down into melatonin, which is your sleep hormone. Now, if you're an American and you celebrate Thanksgiving and you eat turkey, then this tryptophan to serotonin to melatonin thing should make sense to you. You've experienced this before. You go, you sit at the table, you eat a bunch of turkey, which contains a ton of tryptophan, and you're at the table with your family and you're feeling good and everyone's happy. You can feel the serotonin rush over you. And then once everyone's done eating, everybody falls asleep on the couch watching football. That's melatonin finally kicking in. That's why you get so sleepy after your big turkey dinner. So tryptophan turns into serotonin, and then serotonin turns into melatonin, which can go to the bloodstream and regulates the circadian rhythm. I'll take this opportunity to make a quick aside and tell you briefly about carcinoid syndrome. I won't go too deep into this, but if you've ever heard of a carcinoid tumor, this is a tumor that secretes serotonin. For this video, what to understand about the implications of a tumor that is pumping out serotonin is it is going to use up a lot of that upstream tryptophan. All that tryptophan is going to be shunted towards the serotonin production pathway. So we're using it all up and directing it away from the niacin pathway. And so in patients with a carcinoid syndrome, they may present with features of a vitamin B3 or a niacin deficiency for that reason. So if we're secreting a bunch of serotonin, we are shunting the tryptophan away from the niacin production pathway to use it in the serotonin pathway. Causes a niacin deficiency because of a tryptophan deficiency. All right, so now let's circle back to that AADC enzyme and talk about AADC deficiency. I'm going to be honest with you guys, this is not a high-yield disorder. Where I've seen this, it's usually been as a wrong answer choice. Remember, AADC is the same thing as dopa decarboxylase. So here's our big diagram of all the phenylalanine breakdown pathways as well as the tryptophan breakdown pathways. And you can see they're kind of linked by BH4 here. And they also both have the AADC enzyme implicated in them. In the disorder AADC deficiency, we are blocking not only the breakdown of tryptophan into serotonin, but also the breakdown of DOPA into dopamine and catecholamines like norepinephrine and epinephrine. So you'll see an increase in these upstream intermediates like tryptophan and DOPA, and a decrease of the downstream intermediates like serotonin and melatonin, as well as decreased dopamine, norepinephrine, epinephrine. So because this enzyme is across these two different pathways, it'll help explain why we get such a broad range of clinical features in AADC deficiency, right? A decrease in AADC will cause an increase in DOPA upstream of that AADC enzyme, and a decrease in the downstream dopamine and catecholamines. That was because AADC was implicated in the phenylalanine breakdown pathway. And then from the tryptophan perspective that we've been talking about in this video, we'll see an increase in that upstream tryptophan and then a decrease of the downstream serotonin and melatonin. So presentation-wise, some of the things we might see are oculogyric crisis, which is characterized by agitation, abnormal eye rotation, upward gaze, uncontrolled head and neck movements, as well as hypotonia. You might also see autonomic dysfunction, learning disability, developmental delay, and sleep disturbance because of all of those different missing neurotransmitters. To diagnose this, most straightforward would be just to measure the serum enzyme activity of that AADC enzyme. You can also do a lumbar puncture to measure the actual level of these neurotransmitters. You can do genetic testing, and then you'll also see an increase in DOPA breakdown products, things like 3-OMD, because of that increased DOPA. A couple of different management options that can all work in tandem here. One is dopamine agonists. Since we have a deficiency in the dopamine itself, we can activate the dopamine receptors to have a similar effect. You can also use monoamine oxidase inhibitors or MAO inhibitors. We talked about these in the last video, but remember monoamine oxidase here is one of the enzymes that breaks down catecholamines. So by giving a MAO inhibitor, we would be able to prevent the further breakdown of our already scarce catecholamines here. And then you can give vitamin B6 because vitamin B6 is a cofactor for AADC, so you can get the AADC that is there to work a little harder. There's also supportive symptomatic treatment, things like benzodiazepines or anticholinergics to kind of help with the movement disorders and the oculogyric crisis, as well as sleep aids to make up for the lack of melatonin. So quick vignette here. Let's say we've got a 3-year-old boy who's referred to a pediatric neurologist for an evaluation of developmental delay and movement abnormalities. The parents are reporting that their child has never achieved typical motor milestones and is having significant muscle weakness. They're also describing episodes where the child's eyes involuntarily roll upwards for extended periods. That's the oculogyric crisis. The child's history is notable for intermittent episodes of autonomic dysfunction, including fluctuations in body temperature and blood pressure. They might not tell you outright autonomic dysfunction. They might just describe that second part, or they might throw you a bone and give you the buzzword because it's kind of a trickier disease. Neurologic exam is revealing hypotonia and a lack of purposeful movements. Laboratory investigations are showing markedly reduced levels of homovanillic acid and 5-hydroxyindole acetic acid, or 5-HIAA, in cerebrospinal fluid. Genetic testing is confirming the diagnosis. So I did make it a little tricky here. What you have to know to understand those lab results: homovanillic acid is a breakdown product of dopamine, and 5-HIAA is a breakdown product of serotonin. So if you've watched this chapter, you would have known the HVA bit. You might not have known what to do with the 5-HIAA, but now you do. And we have reduced levels of these breakdown products because we have reduced levels of their precursors in AADC deficiency. So let's wrap this up. We've been talking about tryptophan breakdown, and there were two major breakdown pathways for tryptophan. There was the niacin pathway and the serotonin pathway. In the niacin pathway, tryptophan got broken down into eventually niacin, and then way down the line, at the end of the line, could be broken down into NAD+ and NADP+, which are electron carriers. Clinical implication to know here is Hartnup disease, which is a deficiency in the neutral amino acid transporter in the gut and in the kidney, leads to a tryptophan deficiency, which in turn leads to a deficiency of niacin, or vitamin B3, which has a very specific clinical picture, including pellagra, which was that triad of dermatitis, dementia, and diarrhea, as well as cerebellar ataxia. And then our other tryptophan breakdown pathway was the serotonin pathway, where tryptophan crossed the blood-brain barrier, was broken down into serotonin with the help of an enzyme called AADC. Serotonin could be further broken down into melatonin, which regulates the sleep-wake cycle. We talked briefly about carcinoid syndrome, which was caused by carcinoid tumors, which secrete serotonin, uses up all the upstream tryptophan, and can lead to a niacin deficiency by shunting the tryptophan away from the niacin pathway and towards the serotonin pathway. And then we talked about AADC deficiency, AADC being the same thing as topa decarboxylase, which led to deficiencies in a wide variety of neurotransmitters, leading to clinical features like oculogyric crisis, autonomic dysfunction, and sleep disturbance. We are done with tryptophan, but we are not done with amino acids. We have more to cover in the upcoming videos, so stay tuned for that. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige, and thank you so much for joining me for our lesson on the metabolism of charged amino acids. Like we discussed in our Intro to Proteins video, there are several charged amino acids. These include arginine, histidine, and lysine as the basic amino acids, and glutamate and aspartate as the acidic amino acids. And some of these charged amino acids, like arginine, histidine, and glutamate, have metabolic pathways that are important to know for the Step 1 exam. So we can start by talking about glutamate metabolism. So up top here is the metabolic pathway for glutamate. We can see glutamate right here in the center of the diagram. And glutamate is the major excitatory neurotransmitter in the central nervous system. So when you think of glutamate in the brain, think of activating effects. Now, glutamate can be made in a couple of different ways. The first way is by deamination of glutamine. So if you go back and take a look at the structures of our amino acids, here's glutamine, here is glutamate. Here's the R group for glutamine, here's the R group for glutamate. And you can see that the only difference between glutamine and glutamate is that glutamine has an amine group right here. So by deaminating that glutamine, right, removing that amino group via enzyme 1 here, which is called glutaminase, which has a vitamin B6 cofactor, we can make glutamate. We can also run that reaction in reverse and add that amine group back to glutamate to turn it into glutamine via a different enzyme here, enzyme 2, called glutamine synthetase. All right, so glutamine to glutamate is one option for making glutamate. The other option for making glutamate is via transamination of alpha-ketoglutarate. Remember, alpha-ketoglutarate is actually a TCA cycle intermediate. And so there are actually two different enzymes we can use to turn alpha-ketoglutarate into glutamate. The first enzyme is enzyme 3 called glutamate dehydrogenase. And that's going to capitalize on the electrons from NADH to facilitate that reaction, leaving us with NAD+, and glutamate dehydrogenase can run that reaction in reverse as well. Now, the other way we can turn alpha-ketoglutarate into glutamate is via enzyme 4 here, which is called aspartate aminotransferase, or AST, which requires a vitamin B6 cofactor. And in that reaction, alpha-ketoglutarate and aspartate will do a transamination reaction, leaving us with glutamate and oxaloacetate, which is another TCA cycle intermediate. In the upcoming video about ammonia transport, we'll be talking a lot more about these reactions. There are lots of important clinical implications here, so this will all be very important to know. For now, just start to get familiar with the pathway, and we'll circle back to it later in the chapter. All right, so let's take it back to the outline, recap what we have so far. Remember, we've been talking about the metabolism of glutamate, which is the major excitatory neurotransmitter in the central nervous system. We had two major ways that we could synthesize glutamate. We could either synthesize it via the deamination of glutamine via the enzyme glutaminase, and remember, we could mediate that reverse reaction as well from glutamate back to glutamine via the enzyme glutamine synthetase. Or if we didn't want to make our glutamate from glutamine, we could make it from alpha-ketoglutarate via transamination reactions. And there were two sort of ways we could go about transaminating alpha-ketoglutarate to turn it into glutamate. The first was via glutamate dehydrogenase, and the second was via AST, or aspartate aminotransferase. So that's what glutamate is and how we make it. Now let's talk about what we can turn it into. One thing we can do with glutamate is we can use enzyme 5 here, which is called glutamate decarboxylase and requires a vitamin B6 cofactor, to turn that glutamate into GABA. And so if you remember how we said that glutamate is the major excitatory neurotransmitter in the central nervous system, GABA is a major inhibitory neurotransmitter. So the activity of GABA will actually balance out the activity of its upstream progenitor, glutamate. And if we were to finish out this metabolic pathway, keep metabolizing GABA, it would eventually turn into succinate, which is a TCA cycle intermediate. So that's one breakdown pathway of glutamate. The other one is glutamate can be broken down into glutathione. And glutathione is a major weapon against reactive oxygen species in the body. If you remember when we talked about the oxidative burst, we said that our phagocytes can use reduced glutathione to help neutralize hydrogen peroxide, which is a reactive oxygen species, down into water. So glutathione, especially in its reduced form, is very important in combating reactive oxygen species. So now back to the outline, breakdown pathways of glutamate. One is glutamate can turn into GABA, or gamma-aminobutyric acid, via a decarboxylation reaction mediated by the enzyme glutamate decarboxylase. This requires vitamin B6 as a cofactor, and this line is a very high-yield point, maybe not necessarily in biochemistry, but definitely in neurology and psychiatry. GABA is our inhibitory neurotransmitter that balances the excitatory activity of glutamate, and GABA can be further metabolized into succinate, which is a TCA cycle intermediate. The other thing glutamate could become was glutathione. Glutathione is a combination of glutamate, cysteine, and glycine. And that glutathione, remember we said, is important for protection against reactive oxygen species. All right, done with glutamate. Now let's move on and talk about arginine metabolism. And there are three major end products of arginine metabolism. It can either participate in the urea cycle, it can create nitric oxide, or it is involved in the production of creatine. So the first and probably highest yield use for arginine is in the urea cycle. And the urea cycle is in charge of ammonia detoxification. And enzyme 6 here, arginase, is going to mediate, in my opinion, one of the highest yield steps of the urea cycle. This is the actual urea producing step of the urea cycle, and we'll talk all about the urea cycle in a future video. Just kind of setting the scene here. In this urea producing step, arginine and water will combine to create urea, which is the final detoxified product that will be excreted in the urine, and we are left with ornithine, which can participate in future rounds of the urea cycle. And like I said, we'll talk all about that in a future video. So arginine to ornithine in the urea cycle is one pathway that arginine can take. Another pathway arginine can take is it can turn into something called citrulline. Now, citrulline is another intermediate in the urea cycle, although as we'll discuss in that video, arginine to citrulline is not the typical order of how we do things in the urea cycle. This reaction's a little bit different, and I don't really want you to associate it with the urea cycle so much, even though both of these ingredients are a part of it. The reaction is mediated by enzyme 7 here called nitric oxide synthase, which requires tetrahydrobiopterin, BH4, as a cofactor. And the important part of this reaction, as the enzyme name suggests, is that nitric oxide is going to be created as a byproduct of this reaction. And nitric oxide is a vasodilator. All right, so we can turn arginine into urea, we can turn it into nitric oxide, and finally we'll talk about how we can turn it into creatine. The first step here, arginine is going to combine with glycine, and it will put out ornithine, which is a urea cycle intermediate that we already talked about here, as well as the intermediate guanidinoacetate. Guanidinoacetate can be methylated with S-adenosyl methyltransferase, SAM here, to create creatine. So if you remember our activated methyl group cycle, we had this S-adenosyl methionine, or SAM, which was a 1-carbon carrier. And the carbon from SAM could be put onto various acceptors by the activity of methyltransferases to methylate those acceptors. So one acceptor is guanidinoacetate. And with the help of SAM and its methyl group, we can methylate that guanidinoacetate and turn it into creatine. And we did a whole video on creatine earlier on in this unit, so you can go ahead and watch that if you need a review. But remember, creatine held energy similarly to ATP in the form of phosphate bonds. We have creatine stores in our body that we can call upon as the first line of defense for a quick burst of energy before we start to utilize ATP. So back to the outline, one of the first things that we could do with arginine was have it participate in the urea cycle, which remember was a process for ammonia detoxification and excretion. Like we said, we'll have a whole video on this coming up, but just as a primer, arginine will turn into ornithine via the enzyme arginase. That ornithine is an intermediate in the urea cycle, and the arginase reaction is what actually is the urea producing step. The next thing we could do with arginine is we could have it react via nitric oxide synthase to turn into citrulline and create nitric oxide as a byproduct, nitric oxide being an important vasodilator in the body. Then finally, we could use arginine to make creatine. Arginine and glycine would combine to turn into guanidinoacetate, as well as ornithine. And then that guanidinoacetate could be methylated into creatine via S-adenosylmethionine, which was an old friend of ours from the 1-carbon metabolism chapter. All right, so enough about arginine. Let's finish off by talking about histidine. Honestly, probably didn't even need to make a diagram for this. Big thing to know about histidine is it can turn into histamine via enzyme 8 here, histidine decarboxylase, which has a vitamin B6 cofactor. So histidine into histamine via histidine decarboxylase, that has a B6 cofactor. And I'm sure you're already aware of the importance of histamine. Histamine is involved in the immune response, inflammation, and neurotransmission, including alertness. Anyone with allergies is already well acquainted to histamine and antihistamine medications. Now, there are other breakdown pathways of histidine. One involves histidase. You don't necessarily have to know what histidase does other than it is another breakdown pathway of histidine. The only reason I'm even bringing it up is because there is a low-yield disorder called histidinemia where that histidase enzyme is deficient and you'll get a buildup of histidine in the serum. That doesn't do a whole lot. It's usually an asymptomatic disorder. Sometimes you can see some birth complications or intellectual disability. Like I said, low-yield disorder, just something you might see in the answer choices from time to time. So let's wrap this up. We've been talking about the metabolism of charged amino acids, specifically the charged amino acids glutamate, arginine, and histidine. We could make glutamate from glutamine or alpha-ketoglutarate and turn glutamate into GABA, the inhibitory neurotransmitter, or glutathione, which was important in protection against reactive oxygen species. Arginine could participate in the urea cycle, the synthesis of nitric oxide, or the synthesis of creatine, and histidine could be broken down into histamine via the enzyme histidine decarboxylase. There is another enzyme that breaks down histidine called histidase, which I really only mention because there is a disorder called histidinemia where that enzyme is deficient. We get a buildup of histidine in the serum, and that's all we'll say about that. We've got more amino acids to cover in the upcoming videos, so stay tuned. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on cystinuria and organic acidemias. Now, if you remember, many chapters ago, we talked about the breakdown pathways of homocysteine. If you take a look at the diagram that we used to discuss this, right, in the middle was homocysteine, and homocysteine could either undergo the transsulfuration pathway, create cysteine, or it could kind of go the other way here and go through methionine, the organic acids, and eventually join the TCA cycle. So in this video, we'll be talking about disorders within those two breakdown pathways. The first disorder we're going to be talking about is called cystinuria. And before we really get into cystinuria, it is important to understand the difference between cystine and cysteine. So cysteine was what was created through the transsulfuration pathway of homocysteine. Cysteine is two cysteines linked together by a disulfide bond, so linked together by their sulfur groups. So cystinuria is an autosomal recessive defect in dibasic amino acid transport in the proximal renal tubule. The dibasic amino acids that are not being reabsorbed in the proximal renal tubule in this disorder are cysteine, ornithine, lysine, and arginine, right? I know some of these are not the standard 20 proteinogenic amino acids that you're used to, but remember, there are other amino acids in the body. Best way to go about this is just memorizing the mnemonic COLA. So C for cysteine, O for ornithine, L for lysine, A for arginine. So those are the amino acids that are not being reabsorbed in the renal tubule. And most importantly for the disorder cystinuria is going to be the defect in that cysteine reabsorption. If we're not reabsorbing that cysteine, that means it is going to end up in the urine. And so all that cysteine in the urine is going to collect together and concentrate into urinary tract calculi, or stones. And these stones are really the high-yield hallmark takeaway point for cystinuria. So this will present with flank pain, hematuria, UTI, or recurrent nephrolithiasis, all symptoms surrounding obstruction and damage from these cystine stones. And so from clinical presentation alone, you're not going to necessarily know that this is cystinuria, right? There are lots of things that cause kidney stones. But because this is an inherited defect, you can narrow your differential a little bit because oftentimes this will present with recurrent kidney stones in children. Generally, when you're seeing recurrent kidney stones in a child, you're either thinking something anatomical or you are thinking of an inherited condition like this. You're not thinking like a red meat and alcohol presentation. So, all right, recurrent UTIs and kidney stones and things in a kid, how do we lock down our diagnosis of cystinuria? We'll do a urinalysis or a stone analysis. And on this analysis, you'll see an increase in cystine in the urine as well as hexagonal crystals. So take a look at our image here. This is a very high yield image to know. Oftentimes in urinalyses and stone analyses, they'll make you tell apart the different kinds of kidney stones based on what the crystals look like. So whenever you get to the renal unit, you will learn that different types of kidney stones have different crystal shapes and buzzwords associated with each shape. So a calcium oxalate stone is envelope shaped, or a struvite stone has coffin lid shaped crystals, and you'll get to know all of those images. This is the image and the buzzword to know for a cystine stone are hexagon-shaped crystals. You can also diagnose this condition with genetic testing, looking for the SLC3A1 or SLC7A9 genes. And then you can do a test called the urinary cyanide nitroprusside test. This is how you actually test for that elevated cystine in the urine. You will take the urine and you will add cyanide to it, and if there is an elevated level of cystine, then the cyanide and the cystine will react to break apart that cystine into cysteine, right, the original amino acid. And cysteine, in the presence of nitroprusside, will turn a red color. So a urine sample that is elevated in cysteine, when it undergoes the urinary cyanide nitroprusside test, will turn red. To manage a cystine stone in cystinuria, what you're going to want to do is increase the solubility of the stone. So encouraging the stone to break up into solution in the urine. We can do that either by alkalinization or by complexation. So we can use things like potassium citrate, sodium bicarbonate, and acetazolamide to make the urine more alkaline and encourage the stone to dissolve into the urine. And then we can do complexation with thiol drugs, which are things like tiopronin and D-penicillamine. Don't memorize those. And then from a preventative standpoint, you're going to do dietary modification, so increasing fluids, decreasing red meat and dairy, and decreasing sodium. Overall, limiting your amino acid intake and also promoting hydration to prevent the concentration of those stones. So let's do a typical clinical vignette for cystinuria. Let's say we've got a 32-year-old guy who's presenting to the urology clinic with a history of recurrent kidney stones since he was a teenager. All right, so our guy's 32 now, but this has been going on since he was a kid. So right off the bat, your differential should be shifting to the pediatric etiologies of kidney stones. He's describing severe flank pain and hematuria during stone passage, to be expected. He's reporting that his urine is cloudy at times and he's noticed some small gritty particles. His father also experienced similar kidney stone issues. So now we've got a family history, we might be thinking something genetic. On physical exam, nothing significant jumping out at you, but urinalysis is revealing microscopic hematuria, and a microscopic exam of the urine sediment is showing hexagonal crystals. Remember, that was our buzzword. And then we've got a urine cyanide nitroprusside test, which is going to be positive. All right, so shifting gears, let's talk now about organic acidemias. The organic acidemias are not as high yield as cystinuria, but still important to be aware of for the step 1 exam. The organic acids in question are propionic acid and methylmalonic acid. So just to quickly review the breakdown pathway of homocysteine, it could first turn into methionine via enzyme 3 here, methionine synthase. Methionine could be metabolized eventually to turn into propionyl-CoA, and lots of different things get metabolized to turn into propionyl-CoA. Remember, we talked about the vomit pathway. Vomit was our mnemonic for valine, odd chain fatty acids, methionine, isoleucine, and threonine. So all of those things kind of merge together into propionyl-CoA. Enzyme 4 here, propionyl-CoA carboxylase, mediates our next reaction, which turns propionyl-CoA into methylmalonyl-CoA. And then enzyme 5, methylmalonyl-CoA mutase, turns methylmalonyl-CoA into succinyl-CoA, our TCA cycle intermediate. Go ahead and check out the video on homocysteine metabolism for a little more information on that. All right, so like we said, our two organic acidemias that we're interested in are propionic acidemia and methylmalonic acidemia. In propionic acidemia, we have a decrease in that propionyl-CoA carboxylase enzyme. That means that we'll get a buildup of propionyl-CoA and a decrease in the downstream methylmalonyl-CoA. Now, propionate, also known as propionic acid, is just propionyl-CoA without that CoA group attached to it. So when you see things like propionyl-CoA and methylmalonyl-CoA, you can go ahead and associate their levels with the unconjugated versions of them. So propionic acid and methylmalonic acid, respectively. So the name propionic acidemia comes from the fact that we are getting a buildup of propionic acid. And we'll also have a decrease, like we said, in that methylmalonyl-CoA, as well as the associated methylmalonic acid. Now, in methylmalonic acidemia, you're going to be deficient instead in that enzyme methylmalonyl-CoA mutase. So in that case, you'll get a buildup of methylmalonic acid upstream of the defective enzyme. Now remember, methylmalonyl-CoA mutase has a vitamin B12 cofactor. So in a vitamin B12 deficiency, you can get a similar clinical picture to a true deficiency in methylmalonyl-CoA mutase. So like we said, methylmalonic acidemia is caused by either a deficiency in methylmalonyl-CoA mutase or vitamin B12. That leads to a buildup of the upstream methylmalonyl-CoA or methylmalonic acid. So we're going to lump our organic acidemias together as a unit while we talk about the clinical presentation. Big one you'll see is a metabolic crisis. So this includes things like vomiting, lethargy, dehydration, and a high anion gap metabolic acidosis, as well as hypoglycemia. So let's take a look at our metabolism map to figure out why that is. In organic acidemias, you've got a defect either here or here. Either way, we are blocking the metabolism of odd-chain fatty acids and making it so that they cannot go to the TCA cycle, right? Normally, these odd-chain fatty acids and all these other things would get broken down. They could join the TCA cycle and they could run up the gluconeogenesis pathway. But now we've blocked that up and we've decreased our metabolism of odd-chain fatty acids, and we're also decreasing our TCA cycle intermediates, right? We're missing that source of succinyl-CoA from upstream. And so by and large, this shuts down the TCA cycle kind of altogether. Like we've discussed in other videos, when the TCA cycle is shut down for one reason or another, acetyl-CoA will shunt over to ketone metabolism and start to make keto acids. So we have a buildup of keto acids and a buildup of organic acids in organic acidemia. Both the organic acids and the keto acids are considered unaccounted for acids when you're calculating the anion gap. They're going to contribute to the anion gap and leave you with a high anion gap metabolic acidosis. All right, so in these organic acidemias, you get a metabolic crisis because you are inhibiting gluconeogenesis, right? You've got a decrease in that odd chain fatty acid metabolism and those decreased TCA cycle intermediates. So we're shutting down the TCA cycle, instead relying on ketone metabolism for energy in the body, which leads to ketoacidosis. That ketoacidosis, in combination with the buildup of the organic acids in organic acidemia, leads to a high anion gap metabolic acidosis. While I cannot promise that that will show up on your Step 1 exam, I think it is a really good review of the metabolism map and the integration of all these different pathways. I think it's worth it for you to understand that as an extra repetition of that material. All right, other clinical presentations you can see in the organic acidemias: poor feeding, hepatosplenomegaly, and then a fishy or a sweaty feet odor. Anytime they comment on the odor of a child in a clinical vignette, you should take note of it. They're not being rude. They put it there for a reason. Other clinical presentations: neurological symptoms like seizures, hypotonia, and encephalopathy. And these are due to hyperammonemia. The reason we get hyperammonemia leading to those neurological symptoms is because of a decrease in urea cycle activity. So we already talked about how we get a high anion gap metabolic acidosis in this condition. That's one reason why the urea cycle shuts off. The urea cycle will also shut off because of a depletion of cofactors like CoA and carnitine, which are important for the urea cycle. You get CoA depletion because a lot of that CoA is sequestered as propionyl-CoA and methylmalonyl-CoA. And carnitine and CoA kind of compete for the same pool of precursors when they're being synthesized. So if we sequester everything as CoA, we don't don't have a whole lot of precursors left to make carnitine. All that is to say, in organic acidemias, urea cycle shuts off, leads to hyperammonemia, leads to symptoms of seizures, hypotonia, encephalopathy, neurological picture. Diagnostics here, looking for organic acids in the urine, and which organic acid you're looking for is going to depend on which organic acidemia you have. Other options include genetic testing and blood testing for metabolic abnormalities like the hyperammonemia or the anion gap metabolic acidosis. To manage this, we are going to want to decrease the patient's intake of proteins and odd-chain fatty acids, and the thought process here is we want to decrease our upstream intermediates. We talked about the vomit pathway that feeds into propionyl-CoA. So by decreasing protein intake, you're decreasing the intake of a lot of these amino acids, and you decrease the odd-chain fatty acid intake in the hopes of reducing some of this buildup. All right, so a clinical vignette for an organic acidemia. Let's say we've got a 6-month-old male infant brought to the ED by his parents due to sudden onset vomiting, lethargy, and dehydration. Not specific, not helpful. Let's keep going. The parents are reporting poor feeding over the last few days, and the infant is appearing unusually drowsy. Again, not specific, not helpful. Let's keep going. On examination, there is hepatomegaly, hypotonia, and the infant is noted to have a distinct fishy odor. Interesting. Okay, fishy odor. That is something specific that we can run with. Now, laboratory analysis is revealing an elevated anion gap metabolic acidosis and an increase in serum propionic acid with normal methylmalonic acid levels. So that would be a propionic acidemia. Something to note here, I didn't make you work for the elevated anion gap metabolic acidosis because I don't know if you've learned how to calculate that yet, but by the time step 1 comes around, it is absolutely fair game for them to not tell you that and just give you a bunch of labs and make you figure that out yourself. So quick wrap up, in this video we've been talking about conditions associated with the 2 major breakdown pathways of homocysteine. Homocysteine, remember, can be broken down into cysteine or into methionine and then into organic acids. The first condition we discussed is cystinuria, which is a defect in the dibasic amino acid transporter in the proximal renal tubule. Those dibasic amino acids being our cholanumonic, cysteine, ornithine, lysine, and arginine. Cysteine, if you remember, was the combination of 2 cysteines linked together. And so a problem reabsorbing cysteine is going to lead to increased cysteine in the urine, which will lead to hexagonal crystals like these, causing recurrent UTIs and kidney stones and obstruction. That image of hexagonal crystals was very important to be able to identify a cysteine stone. We could also do the urinary cyanide nitroprusside test, which would turn red in cystinuria. Management was to increase the stone solubility either through alkalinization or complexation, and then prophylactically doing some dietary modification. Organic acidemias, remember there were 2 major ones that we talked about, propionic acidemia and methylmalonic acidemia. Each of them were deficiencies in different enzymes, but they both have a very similar clinical picture. You'll see metabolic crisis, including a high anion gap metabolic acidosis. You might see a fishy or a sweaty feet odor, neurological symptoms from hyperammonemia. We diagnosed this with urinalysis and genetic testing and blood testing, and our management here was decreasing protein intake to prevent the buildup of the upstream intermediates. We are never done talking about amino acids. There's always more amino acids to cover. We'll talk about them in the next video, but till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on branched chain amino acids. So there are 3 branched chain amino acids, also called BCAAs. They are valine, leucine, and isoleucine. And they're called branched chain amino acids because if you take a look at their R groups, each of them has a branched pattern of their side chains. And the branched chain amino acids can be metabolized into intermediates for the TCA cycle and gluconeogenesis and fatty acid metabolism. The end products of BCAA metabolism are things that you have seen many times before in biochemistry. They're kind of big name products. We have succinyl-CoA, which was a TCA cycle intermediate. We have acetyl-CoA, which is the center of our whole metabolism map. It's sort of the hub between a ton of different metabolic pathways, and acetoacetate, which was part of our ketone metabolism pathway. And so while we are talking about 3 different branched chain amino acids, and you can see that they each have their own metabolic pathways, broadly, there is a pattern to these metabolic pathways. We're going to start with a branched chain amino acid. Then we're going to use branched chain aminotransferase enzymes, or BCAT, to turn the branched chain amino acid of interest into its corresponding alpha keto acid. Once we have the alpha keto acid, our next enzyme is going to be called the branched chain alpha keto acid dehydrogenase complex, or BCKDC. Has a thiamine cofactor right here. And that'll turn the alpha keto acid into its corresponding branched chain acyl-CoA. Each of those branched chain acyl-CoAs has its own end products that it can turn into. Those end products being succinyl-CoA, acetyl-CoA, and acetoacetate. So not every BCAA can make every one of these end products. Each one makes a different combination of them, but that's the general pattern that we're working with. So our BCAA first is metabolized into the alpha keto acid via branched chain aminotransferase, or BCAT. That was a transamination reaction. Then we could use the BCKDC enzyme to turn the alpha keto acid into its corresponding branched chain acyl-CoA. And that BCKDC enzyme had a thiamine cofactor. And then those branched chain acyl-CoAs could go on to form some combination of our key players here, these end products, the succinyl-CoA, acetyl-CoA, and acetoacetate, which are important intermediates in other metabolic processes. So I know this is a big diagram. The important things to memorize here are going to be obviously the names of the branched chain amino acids, the names of BCAT and BCKDC, and the end products that can be made from each of the respective amino acids. Just broadly remember that BCAT makes alpha keto acids, BCKDC turns those alpha keto acids into branched chain acyl-CoAs, and then from there you can get specific again to each amino acid. Not super high yield to learn these names here, but we'll talk through them once just in case. So let's start first by talking about valine. Valine, when acted upon by BCAT, will turn into alpha keto isovaleric acid. That's the alpha keto acid for valine. Then BCKDC will turn that alpha keto isovaleric acid into isobutyryl-CoA. That's the branched chain acyl-CoA form. And isobutyryl-CoA can turn into propionyl-CoA. If you take a look back at our metabolism map, if you remember, the mnemonic that we used for products that become propionyl-CoA was vomit, V-O-M-I-T. The V in vomit stood for valine. And as a spoiler ahead, the I stands for isoleucine. Remember, propionyl-CoA can become methylmalonyl-CoA, which becomes succinyl-CoA, that TCA cycle intermediate. So for valine, it turned into alpha keto isovaleric acid via BCAT, and then BCKDC turned it into isobutyryl-CoA. That could be metabolized into propionyl-CoA, which turns into methylmalonyl-CoA, and eventually succinyl-CoA, which is a TCA cycle intermediate. For isoleucine, BCAT will turn isoleucine into an alpha keto acid called alpha keto methylvaleric acid. Like I said, don't memorize that name. That alpha keto methylvaleric acid will be acted upon by BCKDC to turn into alpha methylbutyryl-CoA. Like we alluded to before, alpha methylbutyryl-CoA can turn into propionyl-CoA, right? Because isoleucine was the I in our vomit pathway that creates propionyl-CoA. So isoleucine then can eventually go on to feed into the TCA cycle. Or alpha methylbutyryl-CoA can also become acetyl-CoA. Acetyl-CoA right here at the center of our metabolism map. So we can participate in fatty acid metabolism or ketone metabolism. It really is the central hub for this whole map. So we've got isoleucine to alpha keto betyl methylvaleric acid via BCAT, and then BCKDC will do its thing to create alpha methylbutyryl-CoA, and that'll go on to either form acetyl-CoA or propionyl-CoA, which eventually becomes succinyl-CoA to go to the TCA cycle. Let's follow the pattern again for leucine. When BCAT acts on leucine, it will form alpha keto isocaproic acid, which will be acted upon by BCKDC to form isovaleryl-CoA. Now that isovaleryl-CoA can be metabolized into HMG-CoA, which we've encountered in a couple different pathways. It can either become acetyl-CoA or it can become acetoacetate, which is a ketone. So leucine metabolism implicates not only acetyl-CoA, but also the ketone metabolism pathway. So back to the outline, BCAT turns leucine into alpha keto isocaproic acid, and then BCKDC will turn that into isovaleryl-CoA, which will eventually be metabolized into HMG-CoA, and then either acetyl-CoA, which can join the TCA cycle and is also implicated in fatty acid metabolism, and that, also holds true for up here with isoleucine, or it can become acetoacetate, which is a ketone. So let's talk about a disorder now called maple syrup urine disease. And maple syrup urine disease is an autosomal recessive defect in BCKDC. So in maple syrup urine disease, we have a defective BCKDC. That means that we will get a decrease in downstream branched-chain acyl-CoAs and a buildup of upstream alpha-keto acids, right? So a decrease in BCKDC is a problem in the BCAA metabolism pathway, specifically the step that turns alpha-keto acids into branched-chain acyl-CoAs. Because of that, you're going to get a buildup upstream of the enzyme of alpha-keto acids. The presentation here is classic. They will give you an infant with sweet-smelling urine, an intellectual disability, CNS damage and seizures due to the increase in leucine, lethargy, emesis, and dystonia. The sweet-smelling urine is where maple syrup urine disease gets its name, and it's a big tip-off. This is another illness script that you should be very familiar with. It's very high yield. This is something that is diagnosed on the newborn screen, or you can also test the serum or urine for elevated alpha-keto acids, especially the alpha-keto isocaproic acid, right? The buildup in leucine, and that's the alpha-keto acid form of leucine, is especially powerful in this disorder. And you'll also see a buildup of BCAAs. And because of the widespread metabolic implications of these end products of BCAA metabolism, you'll also see hypoglycemia, right? Some of these are important in gluconeogenesis, for example. To manage this, decrease the dietary intake of BCAAs. You're also going to want to supplement thiamine, which remember is a cofactor for BCKDC. And then really the only definitive way to go about treating this is with a liver transplant. So let's do a vignette for maple syrup urine disease. Let's say we've got a 10-day-old male infant who's brought to the pediatrician by his parents due to concern about feeding difficulties and vomiting. The parents are saying that the infant has been irritable and lethargic since birth. On exam, there is notable hypertonia and spasticity, right? Falls under the category of dystonia. And then urinalysis demonstrates a sweet maple syrup-like odor. Further testing reveals increased blood levels of leucine, isoleucine, and valine. Again, I've said it before in this chapter, but in disorders like maple syrup urine disease, where you have a very specific clinical finding like the sweet-smelling urine, they want you to be able to diagnose on clinical presentation alone. They might not give you these labs. They might ask you to predict what you might see on a urinalysis. And the answer would be elevated levels of branched-chain amino acids or elevated urine alpha-keto acids. So let's wrap this up. We've been talking about the metabolism of branched-chain amino acids, which are valine, leucine, and isoleucine. The broad pattern that we discussed for breakdown was that our BCAA would be metabolized into an alpha-keto acid via the BCAT enzyme. That alpha-keto acid would turn into a branched-chain acyl-CoA via the BCKDC enzyme. From there, we could go on to form major metabolic intermediates across different pathways in the body. Those big names were succinyl-CoA, acetyl-CoA, and acetoacetate. And different BCAAs could make different combinations of those. So valine metabolism will create succinyl-CoA, which is a TCA cycle intermediate. Isoleucine metabolism will form acetyl-CoA as well as succinyl-CoA, and leucine metabolism will form acetyl-CoA as well as acetoacetate, which is a ketone. And then we talked about maple syrup urine disease, which is a disorder where the BCKDC enzyme is defective, and you're not getting appropriate breakdown of alpha-keto acids into the branched-chain acyl-CoA forms. So you get a buildup of alpha-keto acids and of BCAAs upstream of that defective enzyme. The clinical picture is classic and must know. Thankfully, given the name of the disorder, it's pretty easy to remember. Sweet-smelling urine is your buzzword for maple syrup urine disease. That's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our summary of the high-yield disorders of amino acid metabolism. In this video, we're going through 7 of the highest yield inborn errors of amino acid metabolism that you're likely to see on the Step 1 exam. We're going to talk pretty quickly about the must-know features for each of these disorders. And if you have any more specific questions, you can go ahead back through the unit and find the specific video for each of these disorders. With the exception of homocystinuria, which was covered earlier in the biochem unit, all of these videos took place during this chapter on protein metabolism. The first disorder we're going to talk about is homocystinuria. The defective enzyme in the condition homocystinuria was cystathionine beta synthase. Now, important disclaimer here, remember when we talked about homocystinuria, there are lots of different types of homocystinuria and lots of different enzymes that can be defective, but in the classic form of homocystinuria, it's a deficiency in cystathionine beta synthase. So here's our diagram where we show homocysteine metabolism, and we've got homocysteine right here in the middle. Enzyme 1 here is cystathionine beta synthase, which normally turns homocysteine into cystathionine. In the classic form of homocystinuria, we are deficient in that enzyme, leading to a buildup of homocysteine upstream. The presentation for homocystinuria includes marfanoid habitus, and that was part of the image I selected over here. You can see features like scoliosis, very long limbs, very long fingers and toes as well. Things like the thumb sign and the wrist sign. You also see ectopia lentis, where the lenses of the eyes will sublux downwards and inwards, and that downwards and inwards direction is important, especially when we talk about our differential diagnoses. Other features of homocystinuria include intellectual disability. You can see cardiac complications from things like premature atherosclerosis. These are patients who get myocardial infarctions at a pretty young age, as well as thromboembolism. Diagnostics here are an elevated urine and serum homocysteine, as you might expect, and you can use a urine sodium nitroprusside test. The other place we saw that test was actually in cystinuria. Urine sodium nitroprusside test will be positive and turn red in the presence of sulfur-containing amino acids, like homocysteine and cysteine. For homocystinuria, your differential diagnosis is going to include Marfan syndrome and the MEN2B syndrome. And this is because all three of these conditions share the marfanoid habitus. And we've talked at length about these differentials throughout this unit, so I won't go through them here again, but you can pause the video and take a look at this Venn diagram here to help you narrow your differential if you want another review. Moving on to our next condition, we have Alkaptonuria. And the representative image I've selected here is black standing urine. That's one of the clinical features that you might see in Alkaptonuria, and that image is one that is very commonly given to you on the exam. The defective enzyme in Alkaptonuria is homogentisate oxidase. This was an enzyme that was implicated in our phenylalanine breakdown pathway. Remember, one phenylalanine breakdown pathway was that phenylalanine turned into tyrosine, which turned into homogentisate, and then homogentisate was broken down into mallyl acetoacetate by homogentisate oxidase, this enzyme 9 here. Alkaptonuria is a defect in that enzyme that leads to a buildup of upstream homogentisate. That homogentisate can deposit across body tissues and body fluids and leave a black discoloration. One thing you'll see is ochronosis, which is a black discoloration of things like the sclera and the cartilage and the tissues of the skin. You'll also see calcification across the body. So this can be calcification in the form of kidney stones, it can be calcification in the form of arthritis. There are lots of different manifestations this can take. Diagnostics, like we discussed, one is black standing urine, where you have the patient give a urine sample and you just put it out on the counter and you see if it turns black. It's a pretty specific finding and one you should definitely know, which is why we selected it for our image. And you can also test the urine or the serum for homogentisate levels. Differential diagnosis here, you might get this confused with homocystinuria. One, because homogentisate and homocysteine sound pretty similar, but also because of some of the cardiac complications that can come from the calcification of the mitral valve, for example, in Alkaptonuria. Remember, we said homocystinuria also has cardiac complications at a young age. Other differential diagnoses include porphyrias, like porphyria cutanea tarda, or PCT, which I haven't taught you about quite yet, but this can be a little confusing because you can also see skin manifestations like hyperpigmentation in PCT that might confuse you with the ochronosis, and you also can get tea-colored urine in some of the porphyrias, and you might see darkened urine and confuse it for black urine. But when I say Alkaptonuria is black urine, like the picture, I really mean it is black. Hemoglobinuria or any blood in the urine could also confuse you because you might see discoloration of the urine. Again, look for black urine. You will not see black urine if it's just blood. Next condition we're going to talk about is phenylketonuria, or PKU. For the picture here, I have the little girl who's showing some of the clinical features like fair complexion and fair hair, as well as eczema. Two of the big types of phenylketonuria that we talked about were the classic form, which was a deficiency in phenylalanine hydroxylase, as well as the malignant form, which was a deficiency in the cofactor for that enzyme called BH4. So remember, the first step of phenylalanine metabolism was turning phenylalanine into tyrosine. When that step was knocked out, that was PKU. The classic form was a deficiency in the enzyme itself, phenylalanine hydroxylase. But remember, that also had a cofactor of BH4, tetrahydrobiopterin. If we were deficient in that BH4 because of a deficiency in its repleting enzyme, DHPR, we would have a clinically similar effect where we're knocking out that step. Presentation here we already started to allude to. A musty odor about the patient is very commonly described. Also things like the fair complexion and the eczema that we talked about with our sample picture, and other things like seizures, decreased growth, and psychomotor delay. PKU can be detected broadly on a newborn screen, and then to figure out specifically whether it's the classic or malignant form, you can do the oral BH4 loading to see whether or not a BH4 deficiency is in fact the problem. You can also check for urine phenylketones. Now, like we said, patients with PKU can have this distinct musty odor. A couple of the other disorders that we talked about also had associated odors, like maple syrup urine disease and organic acidemias. So in PKU, it is a musty odor. In maple syrup urine disease, it is a sweet-smelling urine, and we'll talk about that in a minute. And then organic acidemias, which are not necessarily high yield enough to make it onto our list here, but we did talk about in this chapter, those patients can have a fishy odor or else a sweaty feet odor. And of course, some differences in the clinical presentations as well, but you can see how the odor part might be the tripping point for you. Next condition we're going to talk about is albinism. A representative image here of a boy with oculocutaneous albinism, an absence of pigment in the skin as well as eye features. The deficient enzyme here is the enzyme tyrosinase. So tyrosinase is another enzyme implicated in phenylalanine breakdown, and tyrosinase is in charge of converting dopa into melanin, melanin being pigment. So in albinism, we knock out that step and we are effectively inhibiting the production of melanin. So no melanin means hypopigmentation. Depending on where the enzyme is deficient, you can either get the ocular or the oculocutaneous form. So either just affecting the eyes or affecting the eyes and the skin. This is a clinical diagnosis. And then your differentials are going to include Chidiac-Higashi syndrome and PKU. Chidiac-Higashi syndrome is a lysosomal trafficking defect, and it can result in partial albinism. So clinically, from a pigmentation standpoint, Chidiac-Higashi patients might look similar, but in Chidiac-Higashi, you will also see giant granules in white blood cells on a smear, and these patients will be predisposed to recurrent infections. Those are not features that you see with albinism. And PKU, again, right, we talked about how patients with PKU have a fair complexion, but other than the complexion, clinically, they do look much different, as we've already discussed. Next disorder we're going to talk about is Hartnup disease. And the image I selected here is the dermatitis associated with pellagra, that cape-like rash in the C3-C4 dermatomal distribution. We'll come back to that in a minute, but it's a really important rash to be able to identify. Hartnup disease is a problem with the renal and intestinal neutral amino acid transporter, which causes an inability to reabsorb neutral amino acids like tryptophan. Tryptophan, remember, is metabolized into things like serotonin and niacin, which is vitamin B3. So if we can't reabsorb tryptophan, we've got low tryptophan levels, we're going to get a decrease in that niacin. When you're deficient in niacin, there's a very specific clinical presentation that comes up called pellagra, which is characterized by the 3 Ds, which are dermatitis, dementia, and diarrhea. Dementia and diarrhea should be pretty self-explanatory, and that dermatitis, like we talked about, is that rash in a cape-like distribution along the C3 and C4 dermatome. You can also see a rash in the face and the dorsum of the hands as well. The other thing you'll see here is cerebellar ataxia. This is diagnosed with increased neutral amino acids in the urine. Differential diagnosis here, one of them is primary pellagra. So this dermatitis, dementia, diarrhea picture that is pellagra is just from a niacin deficiency. Hartnup disease is specifically a niacin deficiency caused by a decrease in the upstream tryptophan. But there are other reasons other than a tryptophan deficiency that you could be deficient in vitamin B3. You could have a primary deficiency of the B3 without the problem reabsorbing the tryptophan. Clinically, that would look very similar, and you would have to run more tests to figure out what was going on. The other thing you might confuse this for is cystinuria. And cystinuria might just confuse you because cystinuria is also a problem with amino acid reabsorption in the kidneys. However, while Hartnup disease was a problem with a neutral amino acid transporter, cystinuria is a problem with dibasic amino acid absorption in the kidneys. The dibasic amino acids, being remembered by the mnemonic COLA, for cysteine, ornithine, lysine, and arginine. As the name suggests, though, the cysteine is really the important one. That cysteine will concentrate into stones. So you'll get recurrent kidney stones and symptoms of urinary tract obstruction and infections. So things like flank pain, hematuria, and then UTIs and recurrent kidney stones. To diagnose this, you'll do a urinalysis or a stone analysis where you'll see hexagonal crystals as well as an increase in cysteine. Back over to our representative image for cystinuria here. Knowing this image of these hexagonal stones is incredibly high yield for the STEP exam. You're specifically looking for the hexagon shape of the crystals. And on your differential are going to be other etiologies of pediatric kidney stones. So these are symptoms that are going to appear from a very young age because this is an inborn error of amino acids. So for example, in a young person who has inflammatory bowel disease like Crohn's, they might get calcium oxalate stones. And so understanding the different crystal shapes and locking in this image is going to be really important for narrowing down your differential. And then the last disorder we'll talk about is maple syrup urine disease. I didn't really have a very good image for this one. I just picked a little bottle of maple syrup to remind you of the sweet-smelling urine for which the disorder is named. Maple syrup urine disease is a defect in the branched-chain alpha-ketoacid dehydrogenase complex, or the BCKDC. So remember, in our breakdown pathway for branched-chain amino acids, which included leucine, isoleucine, and valine, we first turned our branched-chain amino acids into their respective alpha-ketoacids, and then those alpha-ketoacids were turned into branched-chain acyl-CoAs by this BCKDC enzyme here. And so maple syrup urine disease is a defect in that enzyme. So you get a buildup of the upstream alpha-ketoacids and a decrease in some of the products downstream, which include not only branched-chain acyl-CoAs, but also things like succinyl-CoA from the TCA cycle, acetyl-CoA, and acetoacetate. The hallmark feature of maple syrup urine disease is, you guessed it, urine that smells like maple syrup. But it's also characterized by things like intellectual disability, CNS damage and seizures, as well as dystonia. This is diagnosed on a newborn screen. You can also look for an elevation in serum and urine alpha-ketoacids, as well as branched-chain amino acid buildup. And you can look for features of hypoglycemia, because a lot of those downstream products like the acetyl-CoA and the succinyl-CoA involved in the TCA cycle, those were all in charge of regulating blood glucose in times of fasting. And then your differentials include the organic acidemias and PKU for reasons we kind of described above, right? You might get a little confused with the odor, but like we said, clinically, these patients are pretty different. And with that, we are done talking about inborn errors of amino acid metabolism. That's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on ammonia transport. When body proteins are degraded, like muscle for example, we're going to liberate out amino groups, or NH2, right? Our proteins are made up of amino acid building blocks, so it makes sense that as we break down these proteins, we're going to be liberating out amino groups. Problem is, the liberation of those amino groups will quickly turn into ammonia, or NH3, and that is toxic. So ammonia is detoxified in the liver, and so in this video we're going to talk about how all that ammonia gets to the liver. The amino groups are going to travel to the liver via the Cahill cycle, also called the alanine cycle. And once we're in the liver, that ammonia can be eliminated via a process called the urea cycle, which we'll talk about in the next video. And important to know about the Cahill cycle, or that alanine cycle, which brings those amino groups to the liver, it is going to require pyruvate from glycolysis. Because it requires pyruvate, this Cahill cycle or alanine cycle is going to be linked to the Cori cycle, which is also known as the lactic acid cycle. We'll get more into it in a bit, and you'll be able to see how those two processes are linked together. So here's our diagram of the alanine cycle. You can see over here to the left is the muscle, and when we break down muscle, we're left with amino acids. And like we discussed, when these amino acids are broken down, they're liberating out amino groups. And so in this diagram, we are going to follow the amino group along through until it gets to the liver, where ultimately ammonia will be detoxified through the urea cycle. So for our first step, we have our amino acid, which has this amino group here, which is what we're going to be passing along to the liver. The first step is going to be a transamination reaction. If you remember from our Intro to Proteins video, a transamination reaction is just the passing of an amino group from one thing to another. And transamination reactions usually require a vitamin B6 cofactor, and this here is no exception. So we're going to take our amino acid and have it do a transamination reaction with alpha-ketoglutarate, which remember is a TCA cycle intermediate. And so we're going to pass that amino group onto alpha-ketoglutarate, and by doing so, we will create glutamate. You can see our amino group here, we can continue to keep track of it. So the amino acid without the amino group is just an alpha keto acid. Right? So the alpha keto acid form of glutamate was alpha ketoglutarate. So by adding the amino group onto alpha ketoglutarate, we just formed glutamate. And we discussed that first in our video on charged amino acids where we talked about glutamate. So that first transamination reaction can take place by a host of different transaminases, also called aminotransferases. It's the same thing if you see them. And there are a bunch of different aminotransferase enzymes that could facilitate this reaction depending on what the amino acid is. And I'll give you a specific high-yield example of that when we get back to the outline. Let's keep moving on through our image for now. So now glutamate is the carrier of our amino group. And now we're going to do another transamination reaction. Glutamate is going to pass the amino group onto pyruvate. Remember, pyruvate comes from glycolysis. So pyruvate is very important to the alanine cycle because pyruvate is the alpha keto acid for alanine. What that means is if you look at the structure for pyruvate and you look at the structure for alanine, pyruvate is just alanine without the amino group. So in our next step, we're going to do another transamination reaction requiring a vitamin B6 cofactor, and the specific aminotransferase that is facilitating this next reaction is called ALT, which stands for alanine transaminase. And in the reaction mediated by ALT, we're going to take the amino group that's now on the glutamate and add it to pyruvate. When we add the amino group to its corresponding alpha keto acid, we end up with the amino acid. So we added the amino group to the pyruvate and formed alanine. And so we followed our amino group and now it is with the alanine. As such, right, we peeled that amino group off of glutamate, turned it back into its alpha keto acid, which was alpha ketoglutarate. So that alpha ketoglutarate has now been recycled. So we have our alanine, which is the holder of the amino group for now in the bloodstream, and it travels through the bloodstream to the liver. In the liver, we are going to do the opposite of the reaction we just finished describing. So ALT, that same enzyme that added the amino group on to glutamate to form alanine, now is going to peel the amino group off of alanine and give it back to alpha ketoglutarate. As such, we reform glutamate, and glutamate now has that amino group. And we've taken the amino group away from alanine, turning it back into its alpha keto acid, which is pyruvate. So all we did over here was just use ALT to undo everything that it did over here on this side of the image. Once we have our glutamate in the liver, that amino group can just pop off of the glutamate, leaving us again with the alpha keto acid, alpha ketoglutarate. That amino group will come off and form ammonia, NH3, and that can be detoxified by the urea cycle, and we'll talk about the urea cycle in the next video. So we've done our job of getting the amino group from the protein breakdown in the muscle all the way over to the liver where it can be detoxified. So back to the outline, remember our first step of the alanine cycle was amino acid breakdown, leading to an amino group being transferred to glutamate, which was our first nitrogen carrier. And we did that via a transamination reaction between an amino acid and alpha ketoglutarate. So we took the amino group off of the amino acid, traded it to alpha ketoglutarate to form glutamate and an alpha keto acid, depending on whichever amino acid you started with. Right? That was a transamination reaction, which was mediated by transaminases or aminotransferases, same thing. Again, dependent on what amino acid you started with. So I'll give you a high-yield example. If the amino acid we started with was aspartate, then the reaction would be taking the amino group off of aspartate, adding it onto alpha ketoglutarate, that would form glutamate, and then the alpha keto acid we would be left with from aspartate is oxaloacetate. And the transaminase that mediates that is aspartate transaminase, or AST. So the reaction mediated by AST is an important one to know because AST has important clinical implications that we'll talk about at the end of this video. So just to show you on this diagram what that example looks like, we would have aspartate as our amino acid. Aspartate would transfer its amino group onto alpha ketoglutarate. That would form glutamate, and then the alpha keto acid we would be left with is oxaloacetate, which is a TCA cycle intermediate, so very important alpha keto acid we've just formed. All right, so that was our first step. Now that we've made our glutamate, we'll do another transamination reaction, this one mediated by ALT, and we'll take the amino group off of glutamate and add it to pyruvate. That will leave us with alanine as well as alpha ketoglutarate. And just to bring this full circle, when we did our video talking about the fates of pyruvate, one of the reactions was mediated by ALT, turning pyruvate into alanine. And so now you understand where that all came from. So once we had made our alanine, and our alanine was the carrier of the amino group, it was going to carry that amino group through the blood and take it to the liver. At that point, we reversed the ALT reaction, still using ALT to just undo what it had done before. And there we reformed pyruvate and glutamate. And this is a high-yield step because it is the intersection of two important pathways. One is the alanine cycle, which we've been discussing, but then by forming this pyruvate, we are giving fuel, the starting reactant, to gluconeogenesis in the liver, right? So we can use that pyruvate to form glucose, right? If you look at our metabolism map, we have gluconeogenesis over here. Once we've made that pyruvate in the liver, we can run it around to run gluconeogenesis. So that's a key intersection between the two pathways, and so that's a high-yield step mediated by ALT. And then in that last step, that glutamate was deaminated, leaving us with alpha-ketoglutarate once again, and that ammonia could go to the urea cycle to be eliminated. All right, so now let's go back to our diagram and we're going to talk about the lactic acid cycle. We already touched upon it, but just to give you the full picture of how these two processes are knit together. In the muscle, glucose can turn into pyruvate via glycolysis, a fact which you are well aware of by now. Pyruvate can either participate in the ALT reaction, or it can turn into lactate and participate in the lactic acid cycle. Remember, back to our fates of pyruvate, pyruvate can turn into lactate via enzyme D here, lactate dehydrogenase, requires a vitamin B3 cofactor, and some electrons from NADH. But that was another thing that pyruvate could do and turn into. The lactate that is made from the lactic acid cycle will go through the blood to the liver, and that reaction by LDH, lactate dehydrogenase, is a reversible reaction. So we can undo that LDH reaction and we'll reform our pyruvate. Remember that pyruvate was also being reformed by the ALT reaction. Either way, now we have pyruvate in the liver, and that pyruvate can run gluconeogenesis in the liver to form glucose. So you can see how tightly linked the lactic acid cycle, or the Cori cycle, is with the alanine cycle. It just depends on which fate pyruvate decides to take. So to recap the lactic acid cycle, in the muscle, glucose can turn into pyruvate via glycolysis. From there, pyruvate can either participate in the ALT reaction and join the alanine cycle, or via LDH, lactate dehydrogenase, that pyruvate can turn into lactate and join the lactic acid cycle. If we do the lactic acid cycle, which is what we're talking about, then that lactate will go through the blood and go to the liver. And from there, the reaction of LDH will be reversed, and you'll reform pyruvate, which can participate in gluconeogenesis. All right, so one sort of way that you can think about the alanine cycle is it's kind of a convoluted way of getting glutamate in the liver, right? By unforming it and then reforming it once we were there. We have another option of getting glutamate in the liver. Instead of disassembling glutamate and reassembling it, we can use glutamate itself as a carrier. So we talked about this a little bit in our video on charged amino acids when we talked about glutamate. So in the alanine cycle, we took an amino group away from glutamate, right? We gave it to pyruvate to turn it into alanine. In the glutamine cycle, instead of removing the amino group from glutamate, we're going to use glutamate itself as a carrier and give it another amino group. The enzyme glutamine synthetase is going to do this, and by adding another amino group onto glutamate, we have formed glutamine. That glutamine can travel to the liver, and once we're in the liver, we can deaminate that glutamine, right? Take away the amino group and reform glutamate. Whether or not we do the alanine cycle or the glutamine cycle, we end up with glutamate in the liver, which can be deaminated, right? And that ammonia can be detoxified via the urea cycle. So the glutamine cycle is just another way of getting ammonia to the liver. This time we're using glutamate as a transporter, and we're going to add an amino group onto glutamate, turning it into glutamine via the enzyme glutamine synthase, and use that glutamine to transport the ammonia to the liver. Once we're there, we can liberate the ammonia via oxidative deamination in hepatocytes. So let's talk about some clinical implications here. There are some very high-yield clinical implications of the aminotransferases that we talked about in this video. The specific ones were AST and ALT, and we're only just going to scratch the surface of this in this video. But AST and ALT are tests of liver function. We call them our LFTs, or our liver function tests. And these enzymes can leach out into the blood, and they can be elevated in things like liver damage or certain diseases or certain medications. ALT is going to be more specific to the liver, right? A lot of ALT activity was happening within the liver. AST is active out among the tissues, right? AST was one of our peripheral transaminases. The reason I bring that up is because in different conditions, AST and ALT will raise in different proportions to each other. So for example, in alcoholic liver disease, AST will be more than double to ALT. And I'll leave the specifics of that to the GI unit, but that's the gist. That's where these liver function tests are coming from. It's from this ammonia transport process. Knowing how to interpret these liver function tests is very, very important for step 1. So here is your introduction. And then another clinical implication is that in fasting or ketoacidosis, you will get an increase in amino acid breakdown. And the more amino acid breakdown you have, the more ammonia you're going to have to deal with. And that is why you can get symptoms of hyperammonemia in a fasting or a ketoacidotic state. So let's wrap this up. We've been talking about ammonia transport and how we get the amino groups from protein degradation, for example, in the muscle, to the liver. And we want to get them to the liver so that they can be detoxified by the urea cycle. There are 2 different ways to get amino groups to the liver. The first is via the Cahill cycle or the alanine cycle, and the second is via the glutamine cycle. In the Cahill cycle, we used a series of transamination reactions to pass the amino group along through different carriers. First, we had our amino acid. So an example we used was aspartate. We took the amino group off of our amino acid and gave it to alpha-ketoglutarate. That left us with glutamate and whatever alpha-keto acid was relevant to the amino acid we started with. So in the case of aspartate, we were left with oxaloacetate. The enzyme that mediated that was AST, aspartate transaminase. Once we had made our glutamate, we could transfer the amino group from glutamate onto pyruvate and form alanine, as well as reforming our alpha-ketoglutarate. The transaminase that mediated that was ALT, which is alanine transaminase. And our alanine was going to be our carrier of the amino group through the blood and take us to the liver. At that point, we could reverse the reaction of ALT to reform pyruvate, which was the alpha-keto acid form of alanine, and leave us back with glutamate. The pyruvate that we left in the liver could participate in gluconeogenesis. And that glutamate that we were left with in the liver could be deaminated, and the ammonia could be put through the urea cycle to be detoxified and eliminated. We talked a little bit about the importance of pyruvate to this cycle and how, because pyruvate is implicated in this cycle, the Cahill or the alanine cycle is very closely linked to the lactic acid cycle, or the Cori cycle. And so the pyruvate here was also important for gluconeogenesis. And then we said, well, in the alanine cycle, we were taking an amino group off of glutamate with the ultimate intention of having glutamate back in the liver, but we could also add an amino group onto glutamate and use glutamate itself as a carrier to take ammonia to the liver. When we did that, we formed glutamine, and so we called that process the glutamine cycle. We could have glutamine go to the liver and be deaminated. And then we wrapped up by talking about some clinical implications, our liver function tests, AST and ALT, and how they're not just random biochemistry enzymes that I'm rattling off at you. They are very important in clinical practice to be able to interpret. And that was how we transported ammonia to the liver for detoxification. Now we're going to dive deeper into the actual detoxification happening with the urea cycle. We'll do that in the next video. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on the urea cycle. So like we talked about in our video on the alanine cycle, when proteins are degraded, so things like muscle, ammonia is ultimately going to be delivered to the liver via the Cahill or the alanine cycle. The urea cycle is how we detoxify this toxic ammonia into a form where it can be safely excreted. So that excretable, water-soluble form of ammonia is going to be urea. So the urea cycle will package ammonia into urea, and that urea can be delivered to the kidneys where it can be excreted in the urine. And a small amount of urea cycle activity can also take place directly in the kidneys. So this is happening both in the liver and then a small part in the kidneys as well. And so here is the structure of urea. So we have a central carbonyl group here that comes from carbon dioxide, and then we have 2 amino groups on either side here. One of these amino groups is going to come from the amino acid aspartate, and the other one is coming either from the alanine cycle or the glutamine cycle. We talked about this in the last video, right? This is the ammonia that we brought to the liver either via the alanine cycle or the glutamine cycle, and now you can see it packaged up into urea. So urea is made up of a CO2, an ammonia from glutamine or the alanine cycle, and another ammonia from aspartate. So here's our diagram of the urea cycle, primarily, like we said, in the liver, although there is some activity in the kidneys. And here we have the mitochondria. You can see some steps of the urea cycle happen in the mitochondria, and the rest are going to happen in the cytoplasm. Let's start by taking a look at our mitochondrial steps. So we can combine CO2 and H2O via carbonic anhydrase into bicarbonate, which is one of our starting reactants, and our other starting reactant is going to be ammonia. So right off the bat, we're combining 2 of the 3 pieces of urea that we needed, right? We've got the CO2 and the ammonia. This is the ammonia that is coming either from the glutamine cycle or the alanine cycle. And so our first step is going to be to combine the bicarb and the ammonia to form carbamoyl phosphate. The enzyme that does this is called carbamoyl phosphate synthetase 1, or CPS1. This is a step that requires ATP, it requires energy to run, and this is the rate-limiting step of the urea cycle. Remember, when we think of rate-limiting steps, we think of steps that we can regulate, and in this case, CPS1 is going to be upregulated by something called N-acetylglutamate, or NAG for short. That's something we'll come back to when we talk about disorders of the urea cycle in the next video. Once we have our carbamoyl phosphate, we are going to combine it with ornithine. Ornithine is a dibasic amino acid. We've talked about ornithine in a couple places throughout this chapter, including our lesson on charged amino acids and our lesson on cystinuria. And ornithine is one of the intermediates in the urea cycle. We're going to take an enzyme called ornithine transcarbamylase and combine our carbamoyl phosphate with ornithine. And we're going to form something called citrulline. And citrulline is going to go to the cytoplasm of the hepatocyte. So from now on, all of the rest of these steps are going to be cytoplasmic steps. All right, so let's take inventory of those mitochondrial steps before we move on. Remember, first we combined ammonia and bicarb to form carbamoyl phosphate. And the enzyme that did that was CPS1. This was an ATP requiring step, and it was also the rate limiting step. Since it's rate limiting, that means that we can use it as a regulatory step. In this case, the regulation is activation by N-acetylglutamate, or NAG. Once we had our carbamoyl phosphate, we were going to combine it with ornithine, which was an intermediate of the urea cycle, and turn it into citrulline. And the enzyme that did that was ornithine transcarbamylase, or OTC. That citrulline would then go to the cytoplasm of the hepatocyte via an ornithine citrulline antiporter. So it'll take an ornithine from the cytoplasm and bring it into the mitochondria in exchange for bringing the citrulline out. So let's talk now about the cytoplasm. Remember, we left off with citrulline, and citrulline is going to combine with aspartate via the enzyme arginosuccinate synthetase to form, as the name of the enzyme suggests, arginosuccinate. Remember, this aspartate was the source of the final ingredient for urea that we needed, that other amino group. So with the activity of arginosuccinate synthetase, we now have all of the ingredients for urea effectively entered the cycle. So up until this point, we've been bringing a bunch of things together. Once we bring in our final ingredient, that aspartate, the rest of the steps are going to start breaking things apart. So once we have our arginosuccinate, the next enzyme called arginosuccinate lyase is going to split the arginosuccinate into arginine and fumarate. Fumarate, remember, is a TCA cycle intermediate. So the fumarate can go off and participate in that, and the arginine is going to stick around to play for the rest of the urea cycle. And then this next step is our last step of the urea cycle, and it is a high yield step because it is actually the urea forming step. So we have our arginine, and the enzyme arginase is going to take that arginine and combine it with water, and out is going to come urea, our final water-soluble product made up of those 3 building blocks we discussed. That urea is water soluble, so it can go to the bloodstream, to the kidneys, and eventually be excreted out in the urine. The other thing that comes out of this arginase step is ornithine. So we're back with that first thing we started with, that ornithine, which you remember initially was what combined with carbamoyl phosphate to start the urea cycle. So now we have more ornithine ready to initiate another turn. So I know there's a lot here. I do have a mnemonic for you to help you remember all of the reactants in this central cycle here. And the mnemonic, I didn't make this up, I'm just passing it along, is ordinarily careless crappers are also frivolous about urination. And I'm not writing that on my slide, but you can see that it shows you starting with ornithine, everything that gets added in and then subtracted out as you go through the urea cycle, finishing with urea. All right, so let's go back and recap. Remember, we left off with citrulline. In our first cytoplasmic step here, citrulline and aspartate are going to combine to form arginosuccinate. The enzyme that did this was arginosuccinate synthetase. This enzyme also requires ATP. Just one ATP though, compared to the 2 required above for the activity of CPS1. Arginosuccinate could be broken into fumarate and arginine via the enzyme arginosuccinate lyase. And then our high yield finishing step here is our arginase mediated step, where arginase will convert arginine into ornithine and urea. And this step requires water as well. Once we've made our urea, we can send it to the kidneys and excrete it in the urine. And the ornithine is free to re-enter the urea cycle and combine with another unit of carbamoyl phosphate. So let's talk about some clinical implications of the urea cycle. We're going to talk a lot about specific disorders of the urea cycle in the next video. For now, we're just going to talk broadly as a bit of a primer for that video. One critical concept is the concept of blood urea nitrogen, or BUN. This is a measurement of urea in the blood. And so as such, it is going to be a measure of renal function, right? It's your kidney's job to take that urea out of the blood and put it into the urine. Urea is freely filtered in the kidney. It can also be reabsorbed in small amounts. And so BUN is going to be elevated when the kidney is not working and not doing its job. Other causes of elevated BUN can include a high protein diet or tissue breakdown. In either case, you are getting an increased breakdown of amino acids, either because you're eating so many amino acids or because you are actively breaking down muscle tissue. And then dehydration is a very common cause of elevated BUN because your kidneys hate to be thirsty. And BUN is a critical lab value to know and understand and master by the time you get to step 1. Talking very surface level here, you look at BUN alongside another lab value, creatinine. Creatinine comes specifically from muscle breakdown, but unlike BUN, it is not reabsorbed and it is not affected by GFR. So BUN and creatinine can both tell you about kidney function, but they respond to changes in kidney function in slightly different ways, so you look at them together. The ratio of BUN to creatinine will determine the etiology of your kidney injury. So let's say we have our kidney here, and here is our renal artery, and here is our urinary tract. And there are 3 major ways that you can injure the kidney. You can decrease perfusion to the kidney, right? So interfere with the blood supply of it before you get to the kidney. We call that pre-renal. You can have damage intrinsic to the kidney, so an issue with the glomeruli or the renal parenchyma. We call that intrinsic renal. Or you can have an obstruction downstream in the urinary tract that causes backup to the kidney. We call that post-renal. Your normal ratio of BUN to creatinine is going to be between 10 and 20 to 1. So 12 to 1, 15 to 1, 18 to 1, BUN to creatinine. In a pre-renal kidney injury, you are going to see a ratio of BUN to creatinine that is greater than 20 to 1. Remember, BUN can be reabsorbed by the kidneys and creatinine cannot. So in a pre-renal AKI, say we're really dehydrated and we're decreasing our perfusion to the kidneys because of reduced blood volume. The kidneys will reabsorb a lot of that BUN as they try to re-increase the blood volume back to baseline. It can only do that with the BUN, can't do it with the creatinine, so you'll see serum ratio of BUN to creatinine, a very high BUN compared to the creatinine. In an intrinsic renal injury, the kidney itself is damaged, so the kidney's ability to reabsorb that BUN is going to be decreased. That means that you're going to see a proportionally lower ratio of BUN to creatinine, less than 10 to 1, because the kidney itself is injured. Now, a post-renal AKI truly is a mixed bag. You know, I have written here that the ratio is going to look normal. It depends on how long everything's been obstructed. It depends on how bad the damage is, if it's crept up and then actually caused an intrinsic renal. So don't worry too much about the ratio for post-renal. This is not a hard and fast rule. But do lock in these values and understand why that's happening. All right, so that's a little bit about blood urea nitrogen, BUN, and its friend creatinine as a little bonus. Now let's talk about hyperammonemia. hyperammonemia, or increased ammonia in the blood, can be caused by inherited causes like urea cycle disorders, or it can be acquired in conditions like liver disease where you can't run the urea cycle because your liver's so sick. And if we understand the pathophys of what happens in hyperammonemia, it'll help us to understand some of the symptoms that come along with it. So we're talking about the condition of hyperammonemia, so increased ammonia. And this is our diagram of glutamate metabolism. When we have increased ammonia, we are going to promote the shift of glutamate into glutamine. We can sequester some of that ammonia, right, by combining glutamate with the ammonia to form glutamine. So when we have high ammonia, we are going to favor the formation of glutamine. This means that there is less glutamate. Now, along these lines, another thing that we're going to see is a decrease in alpha-ketoglutarate. In that high ammonia state, we are going to favor this forward reaction where we sequester ammonia by combining it with alpha-ketoglutarate. And that forms more of this glutamate, which we've already established is turning into glutamine. It's the same principle. We're favoring these forward reactions that are sequestering ammonia. Now, the final finding you'll see is a little bit tricky because it's paradoxical, but we're actually going to see an increase in GABA. And I know that this is confusing because I just finished telling you that we're going to have a decrease in glutamate in hyperammonemia. So wouldn't that lead to a decrease in this downstream GABA here? You would think so. We're actually going to see an increase in the activity of enzyme 5 here, glutamate decarboxylase. The mechanism is poorly understood and it's thought to be basically a paradoxical reaction where even though we're very low in this glutamate, we're going to take anything we can that's remaining and sequester it over into GABA. And the mechanism of this is unfortunately poorly understood, so you're just going to have to take my word for it. But the takeaway point is that you see an increase in GABA in hyperammonemia. So let's go back to the outline and sort of summarize these conditions that we're working with. For the pathophys of hyperammonemia, that increase in ammonia is going to lead to an increase in glutamine as it is sequestered away from that glutamate form. We're going to see an increase in GABA through that sort of paradoxical, didn't really make sense mechanism, just something to memorize. A decrease in alpha-ketoglutarate, and then because alpha-ketoglutarate is a TCA cycle intermediate, you will also see a decrease in TCA cycle activity. So clinical presentation is going to be very important in diagnosing hyperammonemia. There is technically a test for serum ammonia concentration, but it is very poorly reliable. I remember one time I was on the wards, and it was before I knew that that test is poorly reliable, and I recommended ordering it on a patient. And the attending asked me, "Do you have an ice bucket ready?" I said, "No." He said, "Do you have your running shoes on?" I was like, "Not really." And he said, "Do you have the phone number for the head of the lab?" And I said, "No." He said, "Then we are not ordering this on this patient, because in order for this test to be reliable, you have to take the sample, immediately put it on ice, and run it straight on down to the lab where they run it right away. And even then, if you were somehow to be able to coordinate all of that, it still wouldn't be all that reliable." Instead, what you want to do is identify this by the clinical features, which we'll talk about in a minute, and then seek the underlying process. One of the hallmark clinical features of hyperammonemia is asterixis, which is a flapping tremor. So to assess for asterixis, you're going to ask your patient to hold their arms out and put their palms facing you. And in a normal patient, they should be able to hold their arm with their palms facing you and their fingers up towards the sky. But a patient with asterixis will flap their hands downwards. They won't be able to maintain that position that you put them in. And so it's a flapping tremor where they'll flap down and then they'll correct it, and then they'll flap down again and then they'll correct it again. This is because they have difficulty regulating their muscle tone due to that increase in GABA, GABA being an inhibitory neurotransmitter. When you have an increase in GABA, you've got more of that inhibitory input that is preventing you from keeping that muscle tone. Other symptoms include lethargy, slurred speech, vomiting, cerebral edema, and that cerebral edema is caused by the increased glutamine, which causes an osmotic shift, so it'll suck water to the brain, and then blurry vision for a similar reason. Management here, you want to decrease the ammonium. So you can do a low protein diet. I mean, that's not going to help you so acutely. Acutely, you can give lactulose, which is actually a laxative. And the way this is going to work is it is going to acidify the GI lumen. And so all of that ammonia that was in the form of NH3 and could freely go back and forth between the gut and the blood, now it's going to go to the gut and it is going to get acidified and it's going to get trapped in the ammonium form, NH4+, and kind of get locked in the lumen of the gut and get stuck in the feces and be excreted. Another treatment is rifaximin, and rifaximin is actually an antibiotic. It's also working in the gut, and this is going to kill off gut bacteria that make ammonia. Practically on the wards, lactulose is the thing you're going to see the most. So let's wrap this up. We've been talking about the urea cycle, which is how we detoxified ammonia into urea, a water-soluble form, which could go to the kidneys and be excreted in the urine. We had 3 ingredients to combine to make urea. We had CO2, we had ammonia from glutamine or the alanine cycle, and then we had another ammonia from aspartate. In the mitochondria, we combined ammonia from the glutamine or the alanine cycle with bicarb via the rate-limiting step CPS1. That step was upregulated by NAG and acetylglutamate. Carbamoyl phosphate could be combined with ornithine to form citrulline, and that citrulline could go out to the cytoplasm, where it could combine with aspartate to form arginosuccinate. Arginosuccinate could be broken apart into fumarate and arginine via the enzyme arginosuccinate lyase. And then in our final urea forming step, arginine and water reacted via the help of the arginase enzyme to reform ornithine, which could go back and re-enter the urea cycle, and then it also spit out urea, which could go to the kidneys to be excreted. And we had our mnemonic to remember those steps, which was ordinarily careless crappers are also frivolous about urination, starting with ornithine and ending with urea. Then we talked about a couple of different clinical implications. We talked about the importance of BUN, blood urea nitrogen, and how we could take a look at BUN alongside creatinine to figure out the origin of our acute kidney injury, whether it was pre-renal, intrinsically renal, or post-renal. And then we talked about some of the clinical features of hyperammonemia, including asterixis, the flapping tremor, and cerebral edema caused by an osmotic shift from the increased glutamine. We talked about management options, including lactulose. Hyperammonemia can be acquired through liver disease, or you can be born with an inherited disorder of the urea cycle, and that's what we're going to talk about in our last video of the chapter, so stay tuned. Till then, that's all I got for you. Good job, good luck, and keep practicing. Hi everyone, my name is Paige and thank you so much for joining me for our lesson on disorders of the urea cycle. In the last video, we talked about the urea cycle, which was how we converted toxic ammonia into water-soluble urea, which we were able to send to the kidneys and excrete in the urine. It's a long pathway with a lot of steps, and as Murphy's Law tells us, anything that can go wrong will go wrong. So there are lots of disorders within the urea cycle where different enzymes are not functioning. Generally, the urea cycle disorders, and we'll talk about each of them in turn, but broadly, they will present in a newborn, 24 to 48 hours old, with symptoms of hyperammonemia. So in the video on the urea cycle, we talked about the pathophase behind some of these hyperammonemia symptoms. But as a refresher, the symptoms themselves are asterixis, which is that flapping tremor, blurry vision, cerebral edema from the buildup of glutamine, and seizures. The first disorder of the urea cycle we're going to talk about is ornithine transcarbamylase deficiency, or OTC deficiency. OTC was the enzyme that combined ornithine with carbamoyl phosphate to create citrulline. This enzyme is deficient in OTC deficiency, and so you're going to get a buildup upstream of carbamoyl phosphate and of upstream ammonia, right? We can't send these things through the urea cycle to detoxify them. You're also going to get a buildup of ornithine, right? Ornithine is going to get stuck at this step. You won't be able to combine ornithine and carbamoyl phosphate together to form citrulline. So citrulline will be decreased. So OTC deficiency is X-linked recessive, and a decrease in that OTC enzyme is going to lead to a buildup of ammonia and carbamoyl phosphate, like we discussed, and decreased citrulline. We'll also see a buildup of ornithine, like we discussed. And then let's talk about some of these other findings we're going to have here. The first is going to be a buildup of orotic acid. And that buildup of orotic acid is coming from the buildup of carbamoyl phosphate. Orotic acid is actually something that is covered in the genetics unit. It's part of the pyrimidine synthesis pathway. Here is our pyrimidine synthesis pathway. And as you can see, carbamoyl phosphate is a part of this pathway as well as a part of the urea cycle. In OTC deficiency, remember we have a buildup of carbamoyl phosphate. All that carbamoyl phosphate from the malfunction urea cycle is going to feed into this pathway, this pyrimidine synthesis pathway. And that carbamoyl phosphate will turn into orotic acid. So that'll also be elevated in this disorder. So even though pyrimidine synthesis isn't the exact pathway being affected directly in OTC deficiency, it's still going to be implicated because they share this intermediate. You'll also see a buildup of alanine, which is implicated, remember, through the alanine cycle, which is in charge of bringing ammonia to the liver. And you'll see an increase in glutamine. The elevated ammonia will favor glutamine formation via glutamine synthase. So we talked in some of our other videos about how when ammonia is very high, we are going to favor adding that ammonia onto glutamate to form glutamine. We'll favor this forward reaction here, mediated by glutamine synthase. The presentations for a lot of these disorders of the urea cycle are all going to be pretty similar because they are all largely centered around hyperammonemia. Unlike some of the other disorders this chapter, it's going to be difficult to tell these apart by clinical presentation alone. You're going to probably need some labs. But on clinical presentation, you can expect irritability, failure to thrive, and metabolic encephalopathy, as are all common in hyperammonemia. The diagnosis here might sound obvious, but decreased enzyme activity of OTC, that elevated serum or urine orotic acid, increased carbamoyl phosphate, decreased citrulline, and decreased blood urea nitrogen, BUN. Right, blood urea nitrogen, basically just saying low urea, we're not making urea because the urea cycle is not working. The rest of these labs we already explained. And other than the enzyme activity, you can't look at any one of these labs to tell you what's going on. You need to look at the whole picture, the whole combination, to figure out where in the urea cycle is broken, right? What is building up upstream and what is low downstream? Your best bet, sorry to say it, is just to memorize the urea cycle and be able to draw it out. From there, if you know the deficient enzyme, you'll be able to figure out what's going on upstream and downstream. And that's for each of these disorders. To manage OTC deficiency, a low protein diet to decrease the amount of amino acids to break down and decrease the overall ammonia burden, arginine supplementation. And arginine supplementation just comes into effect because you will overall systemically have low arginine. If you're blocking the urea cycle right here, normally it would be synthesized through the pathway. One medication that you can give too is sodium benzoate. So the benzoate is going to combine with glycine in your body, which is an amino acid. It has an amino group. And when the benzoate and the sodium benzoate and the glycine come together, it will form hippuric acid and sequester some of those amino groups in that hippuric acid. That hippuric acid can be excreted out in the urine. So that's another therapeutic option. And then fluid administration and dialysis. If the ammonia concentration in the blood is so great that this patient is encephalopathic, that is something that is dialyzable, and you can try and mitigate some of the hyperammonemia that way. All right, next condition we're going to talk about is carbamoyl phosphate synthetase 1 deficiency, or CPS1 deficiency. CPS1 was in charge of combining bicarb and ammonia from the alanine cycle or the glutamine cycle and turning them into carbamoyl phosphate. So here you're going to see increased ammonia, but this time you're going to see decreased carbamoyl phosphate. And so because we have the decrease in carbamoyl phosphate, we're not going to have the elevated orotic acid in this condition like we did in the last condition. Remember, the orotic acid was downstream from carbamoyl phosphate. So CPS1 deficiency is autosomal recessive, and all of the rest of these urea cycle disorders are going to be autosomal recessive. OTC deficiency is the only one that was X-linked. And in CPS1 deficiency, we're going to have a decrease in carbamoyl phosphate formation, which leads to an increase in upstream ammonia and a decrease of the urea cycle intermediates downstream. And then, like we said, we do not see the increase in orotic acid here because we do not have increased carbamoyl phosphate. I make a point about this because CPS1 deficiency and OTC deficiency are the two most commonly tested on the Step 1 exam, and they like to know if you know the difference between the two of them. From a lab's perspective, whether or not there is an increase in orotic acid is a great way to quickly tell them apart. Presentation here, again, hyperammonemia symptoms, things like asterixis, lethargy, slurred speech, vomiting, cerebral edema, blurry vision, seizures, and even coma. You can see all those in any of these disorders, right? Those are just the symptoms of hyperammonemia. Diagnosis here: low citrulline and arginine, those are urea cycle intermediates. Elevated glutamine, again due to hyperammonemia, same logic as the elevated glutamine we saw in OTC deficiency. You can also check this out on a newborn screen or do genetic testing. And management here includes general management of hyperammonemia, including low protein diet, sort of more prophylactically, and then acutely lactulose, rifaximin, dialysis, and fluid resuscitation. Lactulose, remember, was our laxative that acidified the GI lumen and trapped ammonia in the gut as ammonium, so you could excrete it out that way. Rifaximin is an antibiotic that kills ammoniogenic gut bacteria. So those first two disorders are really the high yield ones. But there are some other disorders of the urea cycle that they might throw at you. One of those is arginase deficiency. Arginase itself is a high yield enzyme because it is the enzyme that facilitates the urea producing step of the urea cycle. So in an arginase deficiency, obviously you're going to have decreased urea production and an increase in arginine upstream and a buildup of intermediates all the way back. So we'll get a buildup of carbamoyl phosphate. And remember, when you see a buildup of carbamoyl phosphate, that means there's also going to be an increase in orotic acid and obviously hyperammonemia. So arginase deficiency is autosomal recessive, and the decreased arginase is going to lead to decreased urea formation. And you'll see a buildup upstream of arginine, ammonia, and orotic acid. That buildup of orotic acid coming from a buildup of carbamoyl phosphate. Here again, no surprise, you're seeing symptoms of hyperammonemia, either acutely, stress-mediated, or chronically. Presentation is going to be very similar to a CPS1 deficiency. Diagnostics, again, should be no surprise to you. Again, based on the enzyme that's knocked out, you can tell what's going to be elevated upstream and decreased downstream. So you'll see increased arginine, increased carbamoyl phosphate, and you'll see a decrease in BUN, right, because of the low urea. Management here, nothing you haven't seen before: a low protein diet, sodium benzoate, dialysis, fluid resuscitation. Finally, let's talk about NAG synthase deficiency. So NAG, or N-acetylglutamate, remember, was the positive upregulator of carbamoyl phosphate synthetase. So a deficiency in NAG is effectively going to act like a deficiency in carbamoyl phosphate synthetase because we don't have the activator for the enzyme. So NAG synthetase deficiency, autosomal recessive, and decreased NAG leads to decreased CPS1 activity. The presentation, as well as the management, are similar to CPS1 deficiency for that reason. Diagnostics-wise, though, a little bit of nuance. You're going to see elevated ammonia and ornithine with normal urea cycle enzyme levels, right? So all the levels of the enzymes themselves are going to be normal. The problem is with the activator to the enzyme. So the most straightforward way to diagnose this would be genetic testing. So those are the disorders of the urea cycle, but urea cycle disorders are not the only reason that you can get hyperammonemia. So let's talk through a differential for someone who's got symptoms of hyperammonemia. One high yield one that they like to test because they like to see if they can trip you up is orotic aciduria. And the reason they like to ask about that is because orotic acid is elevated in many of these disorders. And they want to know, can you tell, is it a urea cycle problem or is it a problem with pyrimidine synthesis? So orotic aciduria is a problem in pyrimidine synthesis. It's a defect in UMP synthase, which for this video, you just need to know is the enzyme that breaks down orotic acid into UMP in the synthesis of pyrimidines. So as the name suggests, you see an increase in orotic acid in this disorder. However, in orotic aciduria, right, like I said, it's a problem in the pyrimidine synthesis pathway. When we have problems with DNA synthesis, that leads to anemia. Remember, in the urea cycle disorders where we were getting an elevation of orotic acid, we were getting that because we had an increase in carbamoyl phosphate, right? That was coming from the broken urea cycle. We got this buildup. But in the urea cycle disorders that presented with elevated orotic acid, we were getting that orotic acid not because there was any problem with pyrimidine synthesis. We were just getting that buildup because we had so much carbamoyl phosphate. When we had that buildup of carbamoyl phosphate, it shunted over to this pathway and ran down the pathway. And so we got the elevated orotic acid by running the pathway. The key takeaway here is that in the urea cycle disorders, pyrimidine synthesis is totally unaffected, which means that in the urea cycle disorders, you don't see the anemia that you see in orotic aciduria because pyrimidine synthesis is totally fine. The problem is with the urea cycle. So orotic aciduria was a defect in pyrimidine synthesis, and defects in DNA synthesis, like pyrimidine synthesis, can cause megaloblastic anemias, as well as developmental delay. And so yes, you see an increase in orotic acid in orotic acidurias, like you can see in some of these other disorders of the urea cycle, but the anemia here is unique to the orotic aciduria. This is a high yield point. So you should be able to tell apart these three high yield conditions. They like to all test them together. OTC deficiency has elevated orotic acid with no anemia. CPS1 deficiency has no orotic acid elevation and no anemia. Orotic aciduria has elevated orotic acid and anemia. So now you know, rep that, don't get them mixed up. Other things on your differential include organic acidemias. You can see hyperammonemia in organic acidemias from the inhibition of CPS1, but in the organic acidemias, you'll also see clinical features like metabolic acidosis and ketotic hypoglycemia. You can also see hyperammonemia in fatty acid oxidation defects. But remember, the buzzword for fatty acid oxidation defects is hypoketotic hypoglycemia. and this will also present a little later than 24 to 48 hours. And finally, you can also see hyperammonemia in disorders of pyruvate metabolism. Remember how closely pyruvate is implicated in the alanine cycle, but in those disorders, you will frequently also see a lactic acidemia that you won't see in the urea cycle disorders. So let's wrap it up. We've been talking about disorders of the urea cycle. Remember, the urea cycle was how we detoxified ammonia. So disorders of the urea cycle are going to present with symptoms of hyperammonemia. And there were several different enzymes that could be deficient: OTC, CPS1, arginase, and NAG synthetase, which makes NAG. And these all presented with features of hyperammonemia, so things like asterixis, blurry vision, cerebral edema, seizures. And depending on which enzyme was deficient, you would see an increase in the upstream intermediates and a decrease of the intermediates downstream from the affected enzyme. We talked about a trick scenario that they just love to throw at you, where they make you figure out the difference between OTC deficiency, CPS1 deficiency, and orotic aciduria, which is a defect in pyrimidine synthesis. And remember, to tell all these apart, you're going to look at the level of orotic acid and the presence or absence of anemia. Each of those disorders had a different combination of those features. And these things were managed by decreasing the overall ammonia burden in the body, either medically or through diet or through dialysis. And that's all I have for you for this chapter. If you have any questions, comments, concerns, problems, troubles, worries, hopes, dreams, fears, send them on my way. Otherwise, good job, good luck, and keep practicing. All right, go ahead, take a minute to read through the question, then we'll come back together to talk about the answer. All right, so we have a 13-year-old girl with a history of irritable bowel syndrome who's coming to the clinic because of excessive daytime sleepiness, difficulty maintaining a consistent sleep schedule, and worsening irritable mood over the last couple months. She's reporting frequent nighttime awakenings, trouble falling back asleep. She's also mentioning occasional episodes of dizziness when standing up quickly. Physical exam is revealing a scaly rash on the nape of her neck. That is pretty specific, and that should be ringing buzzword alarm bells. That scaly rash in a cape-like distribution along the back of the neck in those C3, C4 dermatomes should remind you of our image for pellagra, which we talked about when we talked about niacin or vitamin B3. So at least we have one buzzword, but let's try and put the rest of the picture together and we'll keep reading through the question. Neuroexam is revealing a wide-based, staggering gait, as well as difficulty completing rapid alternating movements. The wide-based staggering gait and difficulty with rapid alternating movements, also called dysmetria, is evidence of cerebellar dysfunction. And we're going to come back to why that is relevant in this case, but just something that we're thinking about as we're reading through. We're also seeing delayed deep tendon reflexes. And urine amino acid chromatography is confirming the diagnosis. The question wants to know which of the following biochemical processes is most directly impaired in this patient's condition. All right, so this vignette is describing the clinical picture for Hartnup disease, which is caused by a mutation in the SLC6A19 gene that encodes for neutral amino acid transporters in the kidney and the intestine. And I'll emphasize the word neutral here because that'll be important as we talk through our incorrect answers. But without those transporters, you're not able to reabsorb those neutral amino acids, one of which is tryptophan. Here we have our diagram of tryptophan catabolism. We started with tryptophan. Remember, we talked about how there are two main breakdown pathways. There's the kynurenine pathway, where tryptophan is metabolized into niacin and then eventually downstream into NAD+, or alternatively, tryptophan could be broken down into serotonin and then melatonin. So when we think about Hartnup disease, we can think about it in the framework of the three major metabolites that we're missing. Those were NAD+, serotonin, and melatonin. We can explain each of the findings in this patient by looking at it through the lens of one of these metabolites. So let's start with NAD+. When we're deficient in NAD+, we end up first and foremost with this clinical syndrome called pellagra. Pellagra is characterized by the 3 Ds: diarrhea, dermatitis, and dementia. We get the dermatitis in pellagra because NAD+ is crucial in DNA repair. And so its deficiency can lead to inflammation and hypersensitivity, especially in sun-exposed areas. That's why you get this photosensitive, scaly rash, especially in that cape-like distribution. And sure enough, our patient had that. That's one of the features of pellagra. The diarrhea we see because NAD+ is involved in upholding the integrity of the intestinal epithelia. Without NAD+, you can get mucosal atrophy, and that can lead to malabsorption and diarrhea. That could be one of the reasons why our patient was diagnosed with irritable bowel syndrome. A deficiency in NAD+ can also cause cerebellar dysfunction. This is because NAD+ is involved in the production of ATP in neurons, especially in the cerebellum. The cerebellum is very energy dependent. So like we mentioned, this wide-based, staggering gait is an example of cerebellar dysfunction, right? The cerebellum controls balance. If you are imbalanced, you'll widen your gait and stagger forward to try and stay upright. And rapid alternating movements are also controlled by the cerebellum. Like we said, when you're unable to do rapid alternating movements, we call that dysmetria. So we had multiple physical exam signs that there was cerebellar dysfunction in this patient. And now that neurological dysfunction isn't just limited to the cerebellum, you can also see peripheral neuropathy symptoms. In our patient, we saw delayed deep tendon reflexes. And this can expand to more cognitive dysfunction, which is where we get the dementia, that third D in the pellagra triad. We didn't necessarily see too much outright cognitive dysfunction in this patient. All right, so all of those symptoms were due to a decrease in NAD+. What about the serotonin-mediated symptoms? The first would be mood dysregulation, like our patient's worsening irritable mood. Serotonin stabilizes mood, so when you're deficient, you can be prone to irritability and mood dysregulation. We can also see GI symptoms because remember, serotonin isn't just involved in mood, it's also involved in the gut. 90% of serotonin is produced in the gut in enterochromaffin cells, and its job is to regulate peristalsis and gut motility. Serotonin deficiency leads to slowed motility and visceral hypersensitivity, and those could be additional reasons why this patient was diagnosed with irritable bowel symptoms. Finally, a serotonin-mediated symptom can be orthostatic hypotension, because in the periphery, serotonin can mediate vascular constriction and tone, and helps to regulate the autonomic nervous system. A lack of serotonin means impaired vasoconstriction, and so when you stand up and you kind of need that boost in blood pressure mediated by serotonin-induced vasoconstriction, you won't have that, and you can be met with dizziness when standing, like in this patient. And finally, like we said, serotonin is upstream of melatonin. So if we're deficient in serotonin, we're going to be deficient in melatonin as well. Melatonin is in charge of regulating the circadian rhythm. Deficiency in melatonin is going to lead to sleep disturbances like excessive daytime sleepiness and difficulty maintaining a consistent sleep schedule. So all of our symptoms are in line with Hartnup disease. And we used urine amino acid chromatography to confirm the diagnosis, right? To confirm the presence of those neutral amino acids in the urine, which normally shouldn't be there. They should normally be reabsorbed by those transporters that are deficient in Hartnup disease. So we know our answer is E. This patient has Hartnup disease, and one of the core metabolic defects was decreased NAD+ synthesis because of the absence of the upstream tryptophan and niacin. Let's go through the incorrect answers. Answer choice A is branched chain amino acid metabolism. This is the process that is impaired in maple syrup urine disease. And don't let the amino acid chromatography trick you into choosing this one. Maple syrup urine disease presents in infancy, not in a 13-year-old, with lethargy, poor feeding, vomiting, neurological defects, hypoglycemia, metabolic acidosis, and classically the maple syrup or sweet scented urine, and none of that is present here. So answer choice A is out. Answer choice B is catecholamine synthesis, and you might have picked this if you mixed up tryptophan with tyrosine, and this is easy to do. So this was our metabolic map of tyrosine. And yes, in tyrosine metabolism, we do see downstream catecholamines like dopamine, norepinephrine, epinephrine. And yes, these are involved in autonomic regulation and mood. So maybe that's another reason you landed here. But really, these hallmark features, especially the pellagra, should have pointed you away from that choice. Those are explained by a niacin deficiency and Hartnup disease. So B is out. All right, answer choice C is a nasty, nasty trap answer. dibasic amino acid exchange in the renal tubules. Hartnup disease, remember I was sort of hinting at this earlier, is a problem with the neutral amino acid transporters. That is most notably tryptophan. Dibasic amino acids you can remember with the mnemonic COLA for cysteine, ornithine, lysine, and arginine. That's impaired in Cystinuria, and that's another SLC family gene mutation that affects these amino acid transporters, but it's a different set of amino acids. That presents mostly with kidney stones and urinary issues. Again, we're not seeing that here. Answer choice C is out. Answer choice D, heme synthesis, is representing the class of disorders called porphyrias, which we talk about towards the end of the biochemistry unit. The porphyrias are defects in heme synthesis, and different porphyrias can cause different combinations of photosensitivity and abdominal pain and neurological and psychiatric symptoms. So there are two major porphyrias. One of them is acute intermittent porphyria, and this can have some overlapping symptoms like peripheral neuropathy, abdominal pain, and autonomic dysfunction. The neurologic symptoms in AIP are more like psychosis, seizures, some neuropathy. You don't really see the cerebellar dysfunction, ataxia side of it, and you don't see those cutaneous symptoms like the photosensitive rash. Porphyria cutanea tarda is the one that does cause a photosensitive rash, but it doesn't have the other findings. So this constellation of symptoms together doesn't point you towards any one individual porphyria, so you should be thinking of something else. So answer choice D is out. And then finally F, purine nucleotide metabolism. This is Lesch-Nyhan syndrome. This usually presents with hyperuricemia, self-mutilation, and neurological regression. We don't really see any of those in this case, so answer choice F is out. So in summary, Hartnup disease is caused by a defect in neutral amino acid transporters that results in a deficiency in tryptophan. Tryptophan is upstream of a couple of major metabolites, including NAD+, serotonin, and melatonin, all of which become deficient secondary to that tryptophan deficiency. The deficiency in NAD+ leads to pellagra, which is a constellation of findings of dermatitis, diarrhea, and dementia, as well as some other neurological findings like peripheral neuropathy and cerebellar dysfunction. A deficiency in serotonin leads to mood dysregulation, GI symptoms, and orthostatic hypotension, and also leads to a deficiency of the downstream melatonin, which leads to sleep disturbances. The diagnosis is confirmed by urine amino acid chromatography, which will show increased neutral amino acids in the urine. And that's all I got for you. Good job, good luck, and keep practicing.